to do is have a cross-sectional survey study that I'm hoping to roll out, if the timeline works out, by next year. Our population is really all physicians who are working in emergency departments across Canada who look after adults and children. And this is a lot of the rural emergency physicians and remote emergency physicians in Canada. We're going to be using the CAPE database as our sampling frame, and this is the largest database of emergency physicians in Canada that contains self-consenting emergency physicians who've consented to receive surveys. And in addition to demographics, we're going to be collecting data that's going to be, that we think, pertinent to interpreting the data. So collecting data on practice setting, the number of pediatric patients seen a year, training in emergency medicine, years in practice, as well as any formal procedural courses that have been taken. Now, this is our final list of procedures that we've generated so far. We started out with the 100-odd procedure list that's published by the Royal College, and then whittled it down based on literature review and expert opinion. And we really wanted to focus on procedures that were either really critically life-saving or extremely useful to care for kids closer to home. In terms of our outcomes, primarily, we're going to be looking at really what proportion of physicians feel comfortable performing these procedures in children and how frequently they're performing them. Frequently being defined as within the last year, less than the last year, or never. And then secondarily, and this is the really interesting part for me, is to see if frequency, the comfort of a physician in performing a procedure in children was related to the frequency with which they perform that procedure, not just in children, but also in adults. So is it just a case of the more often you do it, the more comfortable you are with it? Or if that comfort varied with the age group of the child, so the younger the child got, did that comfort disappear? And then the practice settings, so rural versus urban emergency departments, because rural physicians have a unique skill set and are often working in really limited resource settings. And so we thought it would be really interesting and really important to address their needs as well. Our projected future directions, we think that our study has implications for skill maintenance. So, is there a role for pediatric emergency docs to rotate through general ED if general ED docs are more comfortable with some of these procedures? For support, so if there are specific knowledge gaps identified with regard to certain procedures or age groups, then that would be a golden opportunity for pediatric outreach from a tertiary care hospital or knowledge translation platform such as TRAC. And then also, I think the study has implications for education, and especially if there are needs identified, then that might be of interest to family med and emergency medicine residency program directors. Now, coming back to the rural piece, we think that rural physicians are a vital part of the Canadian healthcare fabric, and they are usually in that position where they're looking after everybody from cradle to grave. And I am terrified that my study is not going to get enough opinions from rural emergency physicians and remote emergency physicians. And so part of my reason for being here was to get the word out there on my project. So people are aware that this is happening and will fill out my survey if they see the link for it. But also to pick your brains to see, are there other avenues that I could use, other databases, conferences, societies that I could use to reach rural physicians Canada-wide? And also to pick your brains to see how you would define rural and remote in your studies. Our standing definition at the moment is based on population size, but also distance to access to healthcare. But it seems to be that there are a million definitions for rural and remote out there. And so I was very interested in picking the brains of expert researchers here today to see if there is a consensus definition that is commonly used in the literature from your perspective. I'd like to thank you for the opportunity to present to you today, and I'm happy to take any questions.
So thank you very much. Obviously, this is a much different presentation than I saw a few months ago. The fact you worked at Swift Current and Yellowknife really added some context that I obviously had no idea about before. Perhaps you could tell the audience how you have a few minutes here. Perhaps you could tell the audience how you landed on the procedures that you chose. Disclosure, I work at St. Paul's Hospital in downtown Vancouver, and I've done maybe 4 of those in the past 10 years. So some of them are truly quite rare. I did a couple other ones when I did 6 months of rural family practice in Alberta, but most of those I really have not done. How'd you land on those? Was it did you and Dr. Mechtler just discuss this, or did you run this by rural physicians or generalists, or how was this chosen?
Yes, so it's a great question. We started out, to be honest, with the general emergency medicine pediatric objectives for procedures, and then the PEM objectives based on the Royal College list, and then found ones that were common, just so that was our blanket starting point. And then we reviewed the literature to see what people were doing. So you'll notice there aren't on the list, there isn't central line access, arterial lines, ED thoracotomies, needle cricothyroidotomies, just because people weren't doing them. And so it was, we thought it was not a very pertinent question to ask if people would be comfortable doing that. And we didn't think it was very relevant either. And so we whittled down the list based on just, literature. And then Dr. Mechtler and I, for the most part, had a conversation around what we thought would be the most key procedures that would be either, even if we don't perform them frequently, life-saving, if you're the physician looking after that child, or allow physicians to look after that child closer to home. And so we fully recognize that there are some things like trach tube changes and G-tube changes that people may have never had to do, but are very easy things that might allow a child to be kept in their community. And then we polled a couple of our colleagues at BC Children's, but they're primarily pediatric emergency doctors. So I've informally polled my husband, Frank, just yesterday as I gave him my presentation to see what he'd done, because he's a rural GP who does emergency medicine. But it's still very much in the project development phase. So, if people feel that these are procedures that aren't really relevant to their practice, then we're happy to take some feedback on that.
Yeah, certainly. If anybody else has any comments on what they consider relevant procedures, I think that probably covers most of them. But when you say we, I assume that means you and Dr. Mechtler sat down and discussed it, correct? Yeah, fair enough. I mean, instinctively, these do make sense. And I'm willing to bet there's some pediatric emergency medicine fellows that haven't done all those either. Is that correct?
Yeah, absolutely. I've never actually had to do a trach tube change myself. Although I've been taught several times how to do it, but. Yeah.
All right, fair enough. So there is one comment here. It says, what is the best way to contact you? I don't know if you can read that comment from Shiraz at 9:26 a.m. It says, what is the best way to contact you? I have a colleague at Laval University, Dr. Richard Fleet. He has published extensively on rural ER care, and as a number of these items have included surveys, he may have some advice on how to best conduct your research. I can pass on his contact. So that's maybe a promising lead, and maybe fulfills part of your mission today. So
that would be incredible. Could I just write back in the chat with my email address?
Yeah. And then a second comment here also from Shiraz. Thank you. Perhaps POCUS ultrasound for kids would be a useful survey question, and probably not a bad strategy. Yeah. Check out these AAAs, right?
That's a really
it is a very good strategy.
We do for sure. We do have it just for ultrasound IV, but that would be, I agree, it would be incredibly helpful.
All right, that could probably continue reasonably offline right now. So anyway, thank you very much for sharing, and Shiraz, thank you very much for that comment. It's very nice to hear that, and I'm sure you'll make Dr. Bendy very, very, very happy.
But you,
So what is the best way to transition? Do we have another comment here? Doesn't look like it. Alrighty, so what's the best way to transition to the next speaker?
We can move right to the next speaker. Next speaker is Megan Kinley.
Hey, good morning, everyone. Just checking in that you can see my slides there. Okay, perfect. So good morning, everyone. It's a privilege to be here. My name is Megan Kinley, and I'm a medical student at the Island Medical Program in Victoria, BC. I'm very grateful to be joining you from the traditional territory of the Lekwungen people, specifically the Esquimalt, the Songhees, and WSÁNEĆ. And it's snowing in Victoria today here, so quite a rare event, but it's a beautiful day. I'm very grateful to have the support of Jason Curran, who's supervising my project, as well as Dr. Adam Watchorn, who really provided the basis for this project. So as a medical student, we have the opportunity to participate in what's called a FLEX project in each year of our program, and that really allows us to conduct research in an area that we're interested in. And for my presentation, I was connected with a project that was focused around the use of patient-controlled analgesia during rural interfacility transport in British Columbia. And specifically when I joined this project, it was to look at how to do knowledge translation of the work that had been done previously. So a little bit of background about myself. I'm from the small town of Invermere, BC in the interior. So it's about an hour away from the BC-Alberta border. I love this area. It's in the mountains, lots of nature around, and I'm really interested and passionate about rural medicine. Specifically, I want to do rural practice in the future. I think that it's a really full scope career, and I really love the ability to develop relationships with the land and people that you live with. So I really wanted to do a project around rural medicine. And actually, I wanted to do a project around rural paramedicine. I think that there's a lot of funding and support to do research in the medical field. And yet there's, specifically in rural areas, a lot of patients are really seen by paramedics. And there's not as much, I find, research funding or interest in paramedicine, and yet it has such a huge impact on outcomes. So with that said, I connected to the RCCBC and Jason Curran, who put me in touch with this project, as I mentioned, that was previously conducted. So Dr. Watchorn of Golden, BC connected with paramedics and other researchers in the area who were really looking at a problem that had presented. So in rural BC, almost all paramedics are primary care paramedics, and they're really limited in the scope of practice. So they can't provide opioid analgesic for moderate to severe pain, which means that oftentimes during these transfers, patients do not have their pain well controlled. That really is a significant problem. Often these transfers are in the realm of 5 to 6 hours. It ends up patients get either bolus dosed with a really high potency opioid prior to transport, and then they're sort of excessively sedated. Or alternatively, they're being given nitrous oxide during the transfer, which is really not adequate to control their pain. Paramedics themselves were really upset with sort of the inability to provide better treatment to these patients. And then, of course, patients themselves were not having optimal experiences. So this research was conducted a few years ago. They did a pilot project where patients were set up with a morphine pump prior to transport. And then there was the ability to use that during the transport. And Dr. Watchorn is actually going to be presenting later on in this session a little bit more about the specifics of that project. But essentially, I came in to try and look at, since this project was quite successful, why it hadn't been done in other areas and what we could do to try and promote it and look at some barriers to implementation. Specifically, when I came into the project, we wanted to look at what are the barriers to using PCA at other sites in rural BC, because we think it really does have the potential to improve patient care. What are some facilitators? So why might people be interested in it? Is there suboptimal care at other sites in BC? Who needs to be involved? So we know that this is quite a complex problem. It's probably going to require the collaboration of nurses, physicians, paramedics, and community members. Which sites would benefit? And so, of course, if you're living in a rural area, this is probably going to be more useful than if you're in an urban area where transports are shorter. You don't need that sort of long pain control. And then how do we communicate? How do we get the word out about this study and reach people who it might impact? So the first step of our project, I actually worked on this project last year, was to look at what rural sites might benefit from PCA, and so doing a site suitability analysis. The second stage is what I'm working on now, and it's really determining what barriers and facilitators there are to the implementation of PCA in rural BC. And the way that I hope to achieve that is through conducting a survey of paramedics, nurses, and physicians in these targeted areas that we've selected as being possible sites. And then finally, we're hoping to connect Dr. Watchhorn to some physicians and others in these communities who are willing to serve as site ambassadors to really help develop the program in their area. So last year through my project, we were able to determine 15 referring sites that met criteria as being possibly receiving benefit from this protocol. So those sites were rural areas where there was a referring site that was staffed by basic care paramedics, and they would be sending patients off to a higher level of care that was at least 200 kilometers or 2 hours away. The reason we chose that timing was really that's sort of how long we figured it would be, make the difficulty of setting up the PCA pump worth it. Whereas, as I mentioned, if you had a shorter transfer, it wouldn't necessarily be necessary. You can see the list of the communities here. And so those are who we're going to target to look at if implementation would be helpful of PCA there. So that's really the stage of my project that I'm in now, is the survey. And so I hope to be able in the next few months to send out a survey to rural and remote practitioners to determine what sort of questions or what sort of benefits they would see from this, what challenges they foresee with it, and if they think it's really going to be a useful intervention. And then hopefully, once we get the survey results back, I'd like to be able to publish this work in the BC Medical Journal MD2B section. That's a sort of papers from medical students that are really focused on the BC context. And then also just acknowledging that this intervention is not a cure-all. We know that there's a lot of sort of complex interplays, that people in rural and remote areas have higher healthcare disparities than people in urban areas. And so one of the interventions that's really necessary is kind of increasing the level of staffing and licensing of paramedics in those areas. However, this is an opportunity in the meantime to improve patient care. And then finally, this is, as I mentioned, a really complex interdisciplinary problem. And so we welcome the opportunity to collaborate and connect with others. My last slide is just freezing. Oh, there we go. But thank you very much for your attention. Here's just a photo of my hometown in Invermere from a hike I was on this fall. If anyone has any comments or questions, please feel free to ask me now or get in touch with my email there. Thank you.
Hey, Megan, thanks very much for that. I happen to know a little bit about this project. There's no questions so far there. They may pop up. So there's more of a question for Adam here, but knowledge translation is one thing, implementation is quite another. Can you think of any other people you might have want involved in a project like this?
Yeah,
I think it's a tricky question, but
I think that at a policy level, one of the big stages is that the BC EHS has actually accepted this protocol as part of their standard of care. And so that's a really huge step. We have basically the permission to use the protocol. But I think it's really, and Adam's sort of more focused on this part, but it's really developing those site ambassadors, because we know that it's sort of it requires a bit of momentum to get this set up. And that's one of the barriers we foresee, is just having somebody that's willing to do the training at their site and that sort of thing. So that's really who we need to get involved. And I think maybe there's some role as well for patients and patient advocacy groups to sort of be pushing this forward and to say that it's really not, the standard of treatment that we have right now is not adequate.
Yeah, that's what I was looking for, is patient partners. Now, this is different than, say, medical research and knowledge translation. BC Ambulance Service is essentially a paramilitary organization, which is heavily protocolized. And, things like, having patient partners and knowledge translation is not going to be what convinces them. It'll be lobbying and what do they think and what is the top-down direction. So it's really a tremendous amount of work done by your team to do this. I'd also say, you say 200 kilometers. I mean, let's say it's 185 kilometers. I mean, it's still a pretty rough road. I mean, I work at, again, a major site, and we get transfers from even a half hour away or from Squamish or something, and bouncing down the Sea to Sky Highway is not much fun either. I'd suggest there's probably a role for shorter transfers. One of the issues is that, again, this is for some of the audience who, I'm friends with a large number of paramedics. There's a pretty big divide between the advanced life support and the basic life support. And the advanced life support has quite, their protocols are quite a bit expanded for medication use. And a lot of the basic life support ambulance personnel are very, very good, but so far being restricted from opioid medications is one thing. There's also multimodal analgesia, which could be used. I mean, Gary Andolfato, who's at Royal Columbia, published a study about, I believe, intranasal ketamine for painful conditions, which works out pretty well. There's really a ton of options, many of which are, underexplored. The fact that, someone in Adam's position in Golden, British Columbia, which is, it's far, I've actually worked there before, which is far from in Ivory Tower, that the fact Adam's driving this is pretty remarkable. And the fact that your team is able to do this and influence policy, that's not something that often happens. Usually it takes Victoria, Vancouver, New West, Kelowna to do this. So, for you to be able to do this is pretty impressive. I also have to ask why you're on the island program. If your research in your hometown and where you hope to go back to is in Invermere, are you learning some new stuff on the island?
Absolutely. Well, it's one of the big reasons is we have a really small program here. So it's only 32 students. So that was one of the drivers for me here. And the other closest site, I guess, would be in Kelowna, but that's still 6 hours away from home. So.
Well, it's always good to travel a little bit, right? I mean, I've done some work in rural areas as well, though not recently. And the ability to transfer yourself to a different setting that's outside of your comfort zone is really important, because then you can bring, something back to where you are. What you're doing is pretty remarkable. And I believe Adam's published his findings in the Canadian Journal of Emergency Medicine, which is something that does not often happen. It's quite an accomplishment for someone who practices in a very small center. I don't believe Golden is a CT scanner, right? And for someone to publish a paper in a reasonably major journal from a site without a CT scanner is really a pretty remarkable accomplishment. So the team you're with is very, very, very impressive and can serve as a model for a number of other research projects that arise from non-traditional areas. So congratulations. Are there any other questions or comments from the audience about this? Because this is really impressive work. The entire strategy of implementing something, B, convincing essentially a bureaucracy like the BC Ambulance to do things, and then have a knowledge translation protocol and pathway, which is very well developed and very well thought out. And you can tell this involves multi-year planning. It's pretty remarkable. So if there's any comments about that, would be very impressive. Here's a question again from Shiraz, who's, very motivated this morning. I wasn't clear whether the BCHS transfer advisors can't provide orders from analgesia en route. Will you be able to include this in your research?
That's something that I'm not totally clear on. And again, I wasn't involved in the original research. My piece is just on the knowledge translation. However, as I mentioned, Dr. Watchorn is going to be presenting later this morning. But my understanding is that if it's a basic life support paramedic who's manning the ambulance, which it is almost always in these rural transfers, then they do not have the ability to provide opioid analgesia, despite even if they had an order, is my understanding. But yeah, I'd look to Dr. Watchorn to clarify that.
The other issue is whether the transport advisors are usually physicians, and they probably won't get called for a transfer of a stable patient, even if they do have a painful condition. They're usually around for cardiac arrests, patient declines transfers, agitated patients, for things like that, not for what's considered a routine transfer. You can see this is the difference, right? From a bureaucratic point of view, it's considered a routine transfer. For the patient, it may be very, very bad and offers significant room for improvement. Anyway, thank you very much. A very impressive project. I believe now we're going to welcome Ms. Hui Jun.
Good morning.
Good morning.
Yes, let me share my screen. Thank you so much for having me here today. All right. So my name is Hui Jun. I'm a registered dietitian who's currently practicing in an inpatient outpatient setting here in Prince George, but I was previously working in long-term care. I'm also a Masters of Health Sciences student at the University of Northern British Columbia, and my thesis supervisor is Dr. Shannon Freeman. This research project explores the experiences of long-term care staff on technology-mediated communications during COVID-19 in Northern BC. Is my volume okay? Can everybody hear me just fine? Okay. All right, I'd like to begin by acknowledging that the land on which I study, work, and play is the traditional and ceded territory of the Clay K'e Thoney. When COVID-19 pandemic happened, BC's provincial health officer issued orders that imposed restrictions on the people working and visiting long-term care homes, and technology use within long-term care changed significantly. I wanted to understand how technology was used in long-term care homes in Northern BC during COVID-19 and how that affected paid long-term care staff. So let's talk about the populations working in long-term care. It's in a word heterogeneous. The staff that provide care to long-term care residents hail from many disciplines that provide direct care, for example, nurses and care aides, allied healthcare, for example, recreation therapists, social workers, dietitians, support services staff, food services, environmental services, maintenance, as well as the management. So to answer the question regarding technology use in long-term care during COVID-19, I conducted a secondary analysis of existing qualitative data. So the data corpus was from a larger primary study titled Assessing the Health and Human Resource Impact of COVID-19 in a Long-Term Care Setting in Northern BC. This primary study was a mixed method study with quantitative and qualitative components in the study design. In the qualitative component, long-term care staff from all disciplines were invited to participate in 1 hour semi-structured interviews to share their experiences over the telephone or Zoom. These interviews took place between October 2021 and February 2022. They were recorded and transcribed verbatim. For my research, I identified all sections in the transcript where any kind of technology was mentioned. These were then analyzed qualitatively and organized by themes using Brodin and Clark's 6-step thematic analysis approach. So the graph shows that there was a good spread of long-term care staff across various disciplines who participated in this study. There were 53 original interviews conducted in the long-term care staff, of which 52 participants discussed technology use. So what did the staff actually share? So 4 themes were identified from the data. Technology ameliorates physical distancing requirements and geographical constraints. Technology facilitates information flow, communications, and collaborations. Technology complicates emotional connectedness and relationship building. Supports are needed for technology setup and sustained adoption. Even before COVID-19, technology was part of routine operations of some departments that provided and received service over distance. For these participants, the restrictions on movement to enter or leave long-term care did not have a significant impact on their work. Those that typically came into long-term care homes to provide services or attend meetings reported having to do these things virtually. And this allowed them to service aside from other locations, including from home. Interestingly, the ability to work from another site was perceived positively as adding flexibility, while the ability to work from home was perceived negatively. Many acknowledged the necessity, but did not like being able to take the work and the stress home. Participants also reported having to support virtual visits from families, friends, volunteers, entertainers that previously came into long-term care but had to switch to virtual visits. Technology helped, but did not entirely overcome the challenges from distancing restrictions. Participants reported the availability of both synchronous and asynchronous technologies for communications, which they found helpful. A lot of COVID-19 information from the health authority came in the form of emails, memos, and published on the intranet page. Many people noted that the policies changed constantly, and they were often receiving the same email from multiple sources, which led to an overwhelming volume of information. An important exception to this was that of care aides. These participants reported difficulties with computer access, and that participants of other disciplines also noted and collaborated independently. There was an significant increase in audio and visual communications over the computer or smartphones, and participants reported liking that technology allowed them to show something in the form of video and pictures rather than simply describing it verbally. There were virtual meetings, virtual care conferences, even virtual assessments and consultations. For example, nurses in the study reported that they texted information and pictures of, say, a rash on a resident to the doctor that was outside the long-term care homes. So while many participants said they liked virtual meetings, which they found effective and efficient, many others expressed dissatisfaction. They described not having the same kind of in-person connection without the eye contact and the ability to see body language. Some people in the study said that they felt that the managers were absent, and some managers in the study said that they felt that they were not able to support staff adequately from a distance. Some nurses in the study wondered about the impact on resident-centered care when a doctor was not there in person to lay eyes and hands on the residents. A considerable number of participants noted that residents struggled with the virtual visits due to physical and cognitive limitations, and many families directed their comments and questions to the staff instead of talking to the residents. As such, this staff had questions about the value of virtual visits and the abilities of the residents and families to communicate and connect virtually. Participants in the study also noted that there were low residents participation rates for the virtual versions of activities, where the in-person versions were much more popular and well attended. Participants that attended the virtual meetings regularly described steps that they took to build relationships and promote connectedness virtually by engaging in icebreaker activities and planning virtual team parties. So for the wonderful things that participants observed about technology use in long-term care homes during COVID-19, they also reported having to manage significant challenges without additional supports, or rather without adequate supports, I suppose. So the examples of the challenges that many participants said that they encountered included inadequate infrastructure, inadequate availability and access to equipment, lack of training, scheduling conflicts with having to support workflow coordination and scheduling of residents' virtual activities, as well as technology needs on top of their usual job of resident care, and the lack of staff in general. These challenges affected one another, and thus many participants noted that increased technology led to increased workload on their shoulders at a time where staff shortages have increased in frequency. So for example, participants shared that a consequence of unstable Wi-Fi connection or virtual visits was the need to remain in the rooms of the residents during virtual visits, so that in the event of a dropped connection, they could actually help the residents reconnect online. So where and how the technology was deployed also had a major impact on whether the adoption of technology has sustained. So compare this study participants' observations of virtual care conferences with virtual visits. Both activities use tele or video conferencing technologies housed on computers, tablets, or telephones. Both activities involve the attendance of long-term care staff, residents, families, healthcare professionals. For both activities, studies participants reported struggles with getting familiar or using the hardware devices, unstable Wi-Fi connections. However, for virtual care conferences, study participants reported interest in the continued practice of providing the option for virtual attendance into the future due to the convenience of this technology for the long-term care staff and the residents' families. In contrast, for virtual visits, participants reported significant pressure on their workloads with the need to support residents and their families on top of their usual in-person care activities. Participants reported a significant scale back of virtual visits after the visitation restrictions were lifted, and those that had continued to provide this service voiced their desire either for more staffing support or for the frequency of virtual visits to be reduced even further. So as a dietitian who worked in long-term care before and during COVID-19, I had long wondered about the slow rate of technology adoption in long-term care before COVID-19. This research provides insight regarding the perspectives of some long-term care staff in adapting or adopting new technologies in long-term care in Northern BC. This research also raises questions about the impact of the rapid pace of adoption of technology during COVID-19 and how we might mediate the challenges making emotional connections with people via technology, and what kind of supports for long-term care staff and residents to provide to help them, to help with the sustainability of technology used in the long-term care homes. Thank you so much for your time. I'd like to take the opportunity to acknowledge the Interior University Research Coalition, who are for the people that funded this study, the primary study anyway. The professors that were involved in this study hail from University of Northern British Columbia, as well as Thompson Rivers University, and we partner with the Northern Health Authority for this research project. Sincere thanks also goes to the long-term care staff that participated in the study, and indeed across Northern BC that have worked so hard to provide care for our residents and continue to do so under very challenging circumstances. It was an honor to hear the stories. Are there any questions or comments? It's a topic I'm passionate about, and I'd love to hear your thoughts.
The comment in the chat room is from Dr. D. Taylor. This is such important research. Thanks for sharing. Although there were many challenges, how do you see technology supporting how care staff may gain better understanding of residents and families? I ask, as we know from other long-term care research highlights, how staff like knowing residents from a personal perspective as well.
Could you say that again, please? It was a long comment.
Can you read the comment section? It is a long comment.
Sorry, guys.
Try to bring it up.
Do you want me just to say it?
Sure.
Thanks, Fee. Just first of all, commending you on this research, commending you on your presentation, and just wanting to ask you, because one of the things that was coming up for me, and just to let you know that I've done long-term care research for about 20 years, and I think it's so important. And one of the things we see from frontline staff in particular is they want to understand residents from a personal perspective. So while the technology supported communication, not maybe in the way you thought it might, I'm curious if you think forward, especially when we consider the rural implications. Do you see from your research a way that this might be able to support or facilitate relationships between staff and the families who can't maybe be there all the time, in a way that helps the staff understand residents as people, rather than just what's on their care plan? Because this is something I know that has come up in the research literature quite a bit. Staff want to understand who this person is before they came to live in a long-term care setting. Does that help? I'm sorry about the length, but
yes, that's such a great question. And this research is, it's a very specific research on a point in time. Right? I have my own opinions about the question that you've raised. I do think that there's a role in technology for this, and I think one of the things that this research does talk about is the importance of picking the right kind of technology. So technology that requires, I think, a lot of resident interaction with the physical and cognitive limitations that many of the residents have, that requires a lot of supports from staff, which increases challenge. But if you're talking the technologies that Dr. Taylor, I think, talk about, there are things that we could bring in videos, pictures from families into the long-term care homes, and having that in display, for example, would help residents trigger the memories, and it allows the staff of long-term care to see this and put the resident, to see the resident as a person. They had an entire life before they came into long-term care, and so there are many things I think we can do with technology to help promote this understanding, to give more of that background. But I do think we have to be very thoughtful about what kind of technologies we choose to bring into long-term care, and what kind of needs that they have, right? one of the things, one of the surprises, I don't know why I was surprised, but I was that, something like cleaning, that when you have a piece of technology that's moving between residents, nobody really thinks about the sanitation and sterilization, but we don't sanitize when we think of long-term care as a home. And so we don't think about how we are deeply sterilizing and sanitizing equipment at home. But long-term care homes are also healthcare institutions, and we have those same kind of infection control protocols that are in play as well. And that also plays into what equipment and technology would be appropriate to bring into long-term care. I hope that answers your question.
It does. Again, just great work. Love it.
Thank you.
Thank you very much, Dr. Chiu. That was a very fascinating topic. And
oh no, I'm not a doctor, just a registered dietitian.
Now, I was just going to ask if you have any patient or family partners doing this as well. It sounded like this is primarily care provider opinions.
Yes, it is, because the study was originally, it was to assess the health and human resource impact of long-term care staff who worked in long-term care during COVID-19. So that was where the data really came from. When I did the literature review for this study a year ago, there was very little literature that has been published, but I just redid my lit review last month, and there has been significantly more published papers on tech use and for residents, as well as the perspectives of families, and they all bring very different perspectives into this question. So I'll just quickly answer that. So one example would be that many participants in my study actually said that they doubt the values of virtual visits for the residents, because they didn't think that that residents necessarily understood what was going on, but they saw that virtual visits was of much more value to the families. The literature review that I looked into, there were published papers to suggest that even the families themselves did not find virtual visits to be very satisfying. It was better than nothing, but it was not satisfying. So that now raises the question, if this practice is not satisfying to both the residents and the families, and it creates a lot of work for long-term care staff, is this technology, for example, that we should promote the use of in long-term care?
I guess it's the option of not seeing you at all or seeing you through the phone. There's
exactly right.
Anyway, thank you very much. I'm going to welcome Dr. Denise Jaworski and Stephanie Bevan. Thank you.
Hi, everyone. I'm just going to get it set up here. Can everyone hear me okay? Perfect.
Yes, please go ahead.
Hi, good morning. My name is actually Stephanie Hobson, not Bevan, but just so everyone knows, there was a communication error there. I'm a critical care RN practicing in rural and northern hospitals since 2011. I worked with Dr. Denise Jaworski on this study, and we're happy to share with you a presentation about the review of data collected during the COVID-19 pandemic at a rural and northern ICU. Mills Memorial Hospital is located in Terrace, BC, which is in northwestern BC. MMH, as I'll refer to it, offers critical care services to its approximately 12,300 residents, serving a catchment area of 107,000 kilometers squared, including residents of Kitimat, Nisga'a Nation, Stewart, Hazelton, Haida Gwaii, and Dease. Mills Memorial Hospital ICU offers a 4-bed ICU funded for 2 nurses at a time, and this includes 1 negative pressure room with antechamber and 1 room that has partial negative pressure capabilities. A respiratory therapist from 7 a.m. to 7 p.m. 7 days a week, so just daytime hours, a shared physiotherapist with the rest of the hospital, and 4 physicians covering the ICU, 3 visiting and 1 resident. The data we collected is a contribution to a global effort to better inform management strategies and improve the ability of healthcare systems to rapidly respond to emerging infections such as COVID-19. SPRINT-SARI, Short Period Incidence Study of Severe Acute Respiratory Infection, is a global multi-site observational cohort of patients admitted to participating hospitals and ICUs with severe acute respiratory infections. It also looks at clinical epidemiology and microbiology profiles of patients with SARI. MMH participated in the SPRINT SARI study to not only achieve the above-mentioned contributions, but also to increase rural healthcare representation in data collection and research studies. Data were collected using electronic and hard copy chart reviews that were conducted by a medical student and a research nurse. Study data were collected and managed using REDCap, research electronic data capture tools hosted at the University of Oxford. Data collected was fully anonymized and de-identified and submitted centrally to the electronic system. Using inclusive criteria set out by the International Severe Acute Respiratory Consortium, ICERC, we included COVID positive, either diagnosed by lab testing or clinical symptoms, individuals admitted to ICU with acute COVID pneumonia. The ICU data and clinical characteristics that we identified were gathered amongst 85 adults from November 24th, 2020 to February 28th, 2022. The average age of patients was 57 years old. Male to female ratios were nearly equal. Excluded patients were those with post-COVID complications, incidental diagnoses of COVID, pediatric cases, of which we only had 3. Amongst the individuals admitted to our ICU, the majority of patients admitted had pre-existing health conditions, 44% having excess weight, 42% hypertension, 35% diabetes, chronic cardiac disease, asthma, and chronic kidney disease, as you can see. When our data is compared to all Canadian data from this study, you can see some differences in underlying comorbidities in our cohort, including the higher rates of diabetes and excess weight, and lower rates of chronic kidney disease. This may reflect underlying population differences in chronic disease, as residents of rural, remote, and northern Canada see proportionately higher rates of chronic health conditions due to several challenging factors such as geographic location, accessibility to services and tertiary healthcare centers, poor coordination between healthcare services, and increased staffing shortages amongst its health sectors. Of the 85 patients requiring ICU support at Mills Memorial Hospital, 50 of them required mechanical ventilation at some point during their stay. The mean amount of days on the ventilator was 7 days. However, this only counts their ventilator days at our hospital, not the total number of days on the ventilators, as 41 out of 50 of those mechanically ventilated patients were transferred to other centers. The majority of patients received some form of respiratory support, inotrope or vasopressors, and prone positioning. I'll say from experience that prone positioning was dependent on staff availability and risk of complications related to the patient's medical state. In addition, our center had very little experience with prone positioning prior to COVID-19, so this required rapid mobilization of knowledge and skills of the teams. To mitigate the challenges, we would prone only during daytime hours, avoiding overnight proning when limited supports were available to us. Most of our patients did receive the standards of care set out by the CDC treatment guidelines for critically ill patients with COVID pneumonia. These included an immunomodulatory therapy such as tocilizumab, corticosteroids, and anticoagulation. In addition, a large proportion received antibiotics, which highlights opportunities to improve antibiotic stewardship at our site. Common complications amongst our group was liver dysfunction, acute kidney injury, bacterial pneumonia, hyperglycemia, and others as shown here. Outcomes in our facility reflected our hospital resources and capacity management. For instance, of the 50 mechanically ventilated patients, 41, as mentioned, were transferred to other centers, either for higher level of care or repatriation to home communities. 4 were discharged alive from our site and 5 passed away. Overall, 27% of people admitted to our ICU were discharged alive from our facility and 16% passed away. We did try to take a closer look at the 41 intubated individuals who were transferred. Of these, 21 were discharged alive, 19 passed away, and 1 is still in hospital as of earlier this month. 36 of the transfers were to a higher level of care and 5 were repatriated. Accounting for outcomes post-transfer, this equates to about a 40% mortality rate in patients with COVID-19 pneumonia at Mills Memorial Hospital, a rural ICU in northern BC. If you exclude patients who were transferred back to their home communities after clinical improvement rather than to a higher level of care, we managed to keep 54% of our ICU patients from needing transfer to a higher level of care, which is a significant contribution to a rural community and our provincial COVID-19 response. We participated in the SPRINT-SARI Global Observation Study. The diversity of populations, regions, and resource levels from which the data originates increases the generalizability of the evidence generated and supports comparisons across them. This approach accelerates pandemic response by promoting locally driven, locally relevant knowledge, which is most likely to have an impact on public health policy. It also serves to drive societal benefits beyond health to identify trends in inpatient journeys and inform resource needs in an evolving pandemic. Our data demonstrates that despite the known disparities in rural health care and high-risk populations in northern rural areas, high-quality care and evidence-based treatments were made available to patients who were admitted to the ICU. The increased demand on transport systems for access to higher level of care or lateral transfers for resource reasons is also highlighted throughout examination of patient outcomes. It is imperative that when rural sites are planning for future SARI illness outbreaks such as COVID-19 pneumonia, that rural sites remain adaptable and versatile in planning and execution due to the unpredictable and more vulnerable nature of its environments. Examples of this included the proning example, proning only during daytime. Another is using a team nursing approach when ICU patient ratios cannot be met with one-to-one ICU qualified staff, as well as prioritizing family connection with patients through the use of technology and community connection. In conclusion, rural ICUs are unique with special accommodations and needs. Despite limited resources, we were able to contribute our COVID ICU data to an international study, and it is important for rural sites to be included in innovative health research to increase geographic representation and demonstrate their unique needs and abilities. We'd like to acknowledge the communities in this region, patients and families, of course, impacted by COVID, the research team, the ICU physicians at Mills Memorial Terrace, and the physicians associated with the SPRINT-SARI study, more members of the research team, and of course the Rural Coordination Center of British Columbia. Thank you very much for your time.
So again, that's Stephanie Hobson with Dr. Denise Jaworski as well. Congratulations. No questions in the chat, so I'm not going to talk about COVID here, but obviously remarkable doing this during the midst of a pandemic in a in a non-traditional research site. How did you get involved, and what recommendations would you have for other British Columbia sites to get involved in something like this?
Steph, do you want me to take that one?
Yeah, sure.
Sounds good. Yeah, so I mean, it was, not gonna lie, it was a bit of an uphill battle, but fortunately, this research came around at the same time that Northern Health was really starting to build up their own research capacity and interest. And so they had recently had some research managers and directors joining on, which really helped to push things forward in terms of getting data sharing agreements and contracts in place and everything like that. And so I think one thing that is really important for other rural sites is to make sure that you have good health authority support and buy-in from the beginning, and to work closely with your health authority partners. And then, I mean, the other thing that is always so important is having local champions that really are passionate about the work. And I think the team at Mills Memorial Hospital really wanted to make sure that our stories were heard and the stories of our patients. And so worked very hard despite the incredible clinical demands at the time.
But how did you get involved in the first place? I mean, normally if I was, it sounds like there's an international consortium. I mean, I might look to, it's just, so how did you get involved in the first place? Did you know somebody, or did they reach out to you?
Yeah, so some of my colleagues from when I did my research training at U of T, one of my prior program director there was one of the PIs of the study. And so I heard about it through him. But then there's also the Canadian Critical Care Trials Group, which shares information about studies that are ongoing. And you can kind of link into their emails and webinars and stuff like that to learn about studies that you can join. And I think the important part about this one was that it was all created. I didn't have to create anything. I just had to implement a study that had already been created. And for rural sites, I think that's really a great starting point to get rural representation in research.
Still a tremendous amount of work. I mean, you're essentially, building up a program from a site that, I don't know what the research, to be honest, I don't know what the research background at Mills is, but the ability to collect reliable data, to have motivated people, there's tons of data points to collect, I'm sure. The ability to grind this through ethics, the ability to obtain funding, the ability to get contracts done, that's not easy. And it's quite a testament that you're able to get this done. So congratulations, really something that, in the few years that I've done this, I haven't really heard of, rural British Columbia sites getting involved in large multi-center trials. But if anyone else wants to reach out to Dr. Jaworski or Denise Hobson, feel free to. I think this is a really good model, and it is obviously doable. So congratulations.
Thanks.
Thank you.
This is Nina Gregoire and Dr. Kimberly Kazawetter, and I hope I'm pronouncing that correctly.
Tastes sweeter, very close.
Well, speaking as someone whose name is not the most straightforward, has been, mispronounced more than a few times. Anyway, hopefully that worked out.
Okay. Hi, everyone. Welcome to our presentation entitled eHealth Solutions for Rural Pain Care in the Era of COVID-19, Needs, Interests, and Reality. So as mentioned, my name is Nina, and I'm a doctoral student in the Experimental Psychology program at UBC Okanagan. And my research focuses on improving experiences in healthcare. And I'll be presenting along today with my colleague, Dr. Kim Kasweter, a postdoctoral research fellow with UBC Okanagan and Thrive Health. And her background is in health psychology with a particular focus in chronic pain. So we just wanted to start out with a few acknowledgements. Our research would not have been possible without the help from our research team and collaborators, who you can see here. Specifically, we would like to thank Dr. Mark Nazemi, Dr. Francois Lowe, Dr. Susan Holtzman, and Dr. Paul Davies. Additionally, our research was supported by 2 Mitacs Accelerate grants in collaboration with Thrive Health. And we'd like to quickly acknowledge that this research was conducted on the traditional unceded territory of the Syilx people. And we recognize that teaching and learning took place on this land long before us, and we are grateful for the opportunity to live and work and learn here. So as we know, chronic pain is particularly difficult to manage, and this is in part due to the multidimensional nature of the disorder, which often manifests with complex physical and psychological comorbidities, such as anxiety and depression. These challenges are often compounded in rural and remote areas of Canada, where patients have restricted, limited, or access to care. So research demonstrates that patients in these regions often suffer from higher levels of pain and more severe functional impairments. In addition, we've also seen further complications to pain care with the emergence of the COVID-19 pandemic, including increased rates of chronic pain in general, as well as higher rates of mental health comorbidities. In addition, we've also seen higher levels of burnout among physicians. Despite these difficulties, research does suggest that one potential strategy for improving pain care could be greater uptake and diversification of the use of eHealth technology. And despite the recognized potential, even before the pandemic, the implementation of eHealth technologies into routine care was proven difficult, with low adoption rates observed in clinical practices. The onset of the COVID-19 pandemic forced everyone to pivot, and healthcare was no exception. Nearly overnight, the pandemic necessitated widespread global adoption of virtual care. One recent Canadian study found that the percentage of in-office visits fell by 79.1% and rose 56-fold during the pandemic. So while there's strong implementation or evidence of implementation of virtual visits, physician uptake and implementation of other forms of eHealth technology remains unclear. So with this in mind, we conducted 2 research projects that were designed to explore the use of eHealth technology for chronic pain care. The first study focused on perceptions of patients that were waitlisted at an interdisciplinary pain clinic, and the second study focused on perspectives from primary care providers and pain specialists. And although we collected data from both rural and urban settings in British Columbia, we're just going to focus on our findings from those in rural areas. So for the patient methods, previous studies have found that many people who are waitlisted for pain services experience significant deteriorations in psychological well-being and health-related quality of life. Despite the overall effectiveness of interdisciplinary pain clinics, not all patients will experience treatment success. For example, interdisciplinary pain clinics are prone to high attrition rates, and this is partially due to psychological decline. E-health technologies have found to be helpful across multiple domains. For example, apps targeting anxiety have been found to reduce this negative state, and the online delivery of pain education classes have demonstrated a reduction in psychological constructs that contribute to patient suffering, things like catastrophizing. In this study, we asked 79 rural participants who are patients at a pain clinic in Kelowna, BC, about their waitlist experiences and what role e-health could have played during the wait. And then for the second study, we conducted a cross-sectional survey designed to assess physicians' current use, needs, and attitudes towards e-health technology for the management of chronic pain. So specifically, we recruited 48 rural physicians that were licensed to practice in British Columbia and who treat pain to at least some degree as part of their practice.
And so when queried about e-health technology, rural patients, and we had 79 in our sample, rated themselves as 71% likely to use an online platform to help manage their pain. The features they endorsed as most useful were pain education and tips at 91%, self-management tools at 10%, information about supplemental services at 89%, and the ability to flag notes to their providers at 85%. When we consider these findings in context, we see that certain barriers exist for rural patients. In the case of this study, both rural and urban patients described similar challenges associated with financial aspects of care. However, rural patients endorse significant barriers around transportation and lack of availability of appropriate supplemental services at much higher rates than did their urban counterparts. We would speculate that the desire for tools around self-management and flagging for their physician arises from having fewer overall points of contact with medical and paramedical providers, due at least in part to access problems.
And then similarly, 81% of our rural physicians expressed considerable interest in using e-health technology for chronic pain care. The most preferred features were the electronic collection of patient-reported data at 82%, followed by patient-generated summaries and decision support for tailored treatment plans. However, when we were asking them about their current use in their day-to-day practice, we saw generally low adoption rates for several forms of technology. So as you can see here, only a small percentage of providers reported using e-health to collect patient intake data, patient-reported outcomes, and remote patient monitoring. The most common barriers to use were cost, complexity, and not being familiar with available options.
So together, these findings suggest that there's a strong interest from both patients and providers in using e-health in the management of chronic pain. In particular, physicians indicated the most interest in features that facilitate the delivery of care and automate time-consuming tasks, particularly given the high demand and low access already present in rural communities. In contrast, patients express the desire to be able to self-manage their pain and communicate with their providers through e-health technology. In other words, there was a willingness to put in work to see improvements if given the appropriate tools and means to do so.
However, despite strong interest in e-health and a considerable rise in virtual visits with the pandemic, we saw generally low adoption rates for other potentially beneficial forms of e-health technology. For example, despite expressing the greatest interest in the remote collection of patient-reported data, the vast majority of our sample reported not using this feature in their practice. Based on the barriers that were reported, our findings would suggest that enhanced awareness, training, and funding would likely be required to achieve greater adoption of a broader range of e-health technologies. And so with that, we'd like to thank the Rural Coordination Centre of BC for hosting this important event and for having us. And we're more than happy to answer or attempt to answer any questions you might have. Thank you.
All right, thank you very much. Any questions in the Q&A? No, or in the chat? So thank you very much. That was very well done. So my question is going to be a tiny bit different. And again, it's going to be a question that's not just related to your projects, but can impact other projects. I noticed the logo for an old friend in the intro, namely Thrive Health, who I've had my dealings with. What's it like dealing with for-profit agencies? Because again, an issue we haven't really had come up that much here. How did they approach you? How were they used? How did they fund your research? Did they provide a data platform? What was the interaction there?
So for my research, I don't remember how I got working exactly with them. It was kind of through just it was happenstance, and I kind of landed there. So there was conversations with other people in the department, like supervisors and everything. And then I wound up getting placed because of my research interest. And so Thrive Health kind of wanted to gain this more general exploratory knowledge around this kind of wait list time for people with chronic pain. And so I looked into the literature, I did like a lit review, all of those types of things, and then designed kind of a battery of questions that I wanted to ask to tap into the experiences for people. So this was very much like very exploratory research, very descriptive statistics, just understanding people and their experiences while they were waitlisted. And so we did this also in collaboration with Bill Nome's pain clinic in Kelowna. And so it was their patients who answered the survey. So we asked them a bunch of questions about what they would have liked, what they could have used. And we asked them other questions that were related to their barriers in general during the wait list. And so that was kind of how that played out. There was no vested interest in the findings per se, because it was exploratory. And so although they were an industry partner and supported the research, it wasn't, we weren't like testing any product or anything. So in the future, we will test a waitlist. We'll pilot something for patients who have been waitlisted, but that will go through the clinic, and it will be something that was created in collaboration with the pain clinic to offer those things that they expressed that they wanted, like the tips and management, and kind of just go from there and see how it works, and hopefully it provides some benefit to patients who are waiting. Does that answer?
What's your strategy? What's your strategy for going to be for knowledge translation dissemination? Is an issue that affects everybody, all the 33 participants in this room, myself included. Chronic pain affects their patients. You know, it is critically important. We've seen tons of extra overdoses this year because people can't access their chronic pain providers. It is an issue that literally kills. I'm lucky in the city, I've got access to lots. What are your plans for knowledge translation dissemination to, you know, patients, providers, families in rural British Columbia who will doubtlessly benefit from your findings?
Yeah, knowledge translation is something that we're both very passionate about, and so is Thrive Health. Luckily, they're very supportive of that. So Nina and I will be doing a webinar with Pain BC, actually, summarizing our research in April, and hopefully that will help get our findings out to both patients and providers. Additionally, we've been attending conferences and we'll continue to attend conferences. We have a manuscript that's under review right now as well. I've been working with a community organization, so Seniors Learning in Retirement, to help facilitate some of this in a more kind of palatable way for a general audience. Symposia at the university, kind of just trying to, one, share it generally with the public, and then also, with our scientific community through publication. So, and it's also, I think that some of this will go up because it is for my dissertation work, and so it will also be shared through those avenues.
Excellent. Very, very important. Let's see, let's check the questions here. What do we have here? From Paul Gallant, were any of the findings surprising or unanticipated?
Yeah, I was actually surprised that given the pandemic, we're not seeing a bigger rise in other forms of e-health technology. So things like collecting patient intake data and monitoring your patients remotely, I would have expected to see much higher levels given the pandemic. So these studies were connected kind of right around the midst of the first wave, I would say, and into the second wave. And so not seeing those forms of technology being used was surprising to me. I think it would have been very beneficial for both clinicians and patients. And so I think that really emphasizes that there are still these barriers that we need to get around. It's not currently something that's easy to implement. Mm-hmm.
Excellent. All right. Thank you. And also congratulations on the best Zoom background I've seen in a long time. Thank you very much.
Thank you.
All right, everybody, see you in 5 minutes. Dr. Adam Wachthoorn will be presenting. Let's take a little break here. We're back. Hopefully everyone took a nice nice break. Is this Golden and District Hospital, Adam?
Yeah, it is, Frank.
I did a locum there once and I had a great time. Of course, it wasn't snowing or anything like that, but so everyone, this is Dr. Adam Wachthorn. I hope I'm pronouncing that correctly. Gave a great presentation last year. One of his medical students already presented a little while ago, published his recent research in CGEM, one of the bigger rural study that's ever been done in Canadian emergency medicine. So please fire away.
Thanks for that, Frank. Yeah, so my name is Adam Wachthorn. I've worked in Golden for just over 10 years now. I just got my 10-year pin. And I work mainly in the emergency department. And Golden is located about 250 kilometers away from the closest referral center, which is either Calgary or Cranbrook. And so our major issues in the emerge has always been with transport. And that's been my focus in research, and as well with just problem solving in the emerge. So with what I'm going to talk about with this research, we saw a problem. We wanted to fix it, and we came up with what we think is an innovative grassroots solution and made it happen. But it took strong partnership between our hospital and local paramedics, but definitely changed our practice and improved our patient care. So just to describe the work that we did, I just wanted to start with a case. So this is a 45-year-old man who I saw in Golden Emerge. He was skiing at Kicking Horse and broke his leg. Now we splinted him, treated his pain, but we have to refer him to orthopedic surgery, and that's in Cranbrook, which is located 3 hours away by ambulance. So, how are you going to provide pain control during the ambulance transfer? Our practice was, because paramedics in rural BC and rural Canada can't give any IV analgesia, they can only give Antonox. So our practice was to give sub-Q or IM morphine, cross our fingers, hope this would last for the transport, but it didn't. We had so many cases where patients were suffering in the back of the ambulance and paramedics feeling helpless, which is an awful feeling. We felt like we were providing poor care to these patients and wanted to find a solution. So we said, what if the patient can give themselves pain control during the transfer? The paramedics aren't allowed to give them any IV analgesia, but what if the patient can? So with that, we came up with the idea of giving the patient an IV, hooking the IV up to a patient-controlled analgesia pump, so a PCA pump, and patients providing their own pain during transport. We looked into the evidence, and as you all know, there's lots of evidence for post-op and palliative care pain. In the emerge department, there's a few studies with mixed results, but we could find absolutely nothing with ambulance-based PCA, which was an opportunity for us to create something new and innovative, which was really cool. On top of that, there was no protocols. So we launched a pilot project in Golden in conjunction with BC EHS in 2014, developed protocols with BC EHS. We developed a pre-printed order sheet for physicians and put on numerous training sessions for paramedics, nurses, physicians, and admin. So we started collecting data on our transports from 2016 to 2020. And we started in Golden because we were, in Golden, the site champions. We came up with the idea, and we were located, quite a long distance from our referral centers. And then we also spread the project to Invermere and Cranbrook. And for those of you who aren't familiar with the East Kootenays, I've provided a map of Golden, Invermere, Cranbrook, and then our referral centers, Kelowna and Calgary as well. So our inclusion criteria was pretty simple, actually. It was, anyone in acute pain in our department who were requiring an opioid like morphine and needing a transfer to a referral center. They had to be over 16 years old. And really, they just had to be able to push the PCA button to deliver the medicine. And they had to prove they could push the PCA button before they are transferred. We excluded patients who were unstable in multi-trauma or had a significant head injury. And what we studied were pain scores before and after the transfer was complete. We looked at safety as well in terms of oxygen desaturation as a marker, and then just basic satisfaction scores from paramedics and patients. And what we found, we did 84 transfers with ambulance-based PCA over 3 years. The majority of the transfers, you can see 93% were from Golden, and I'll talk about that in a couple slides. The majority were orthopedic trauma cases, but also, a quarter of our cases are undifferentiated acute abdominal pain needing a transfer, usually for a CT scan and surgical consult. And the average transfer time, 3 hours and 22 minutes. So, pretty long transfers. 3 patients had desaturation episodes below 90%. All of these patients responded with oxygen by nasal prong and did well. We did not have to turn the PCA pump off in any cases or provide Narcan to any of these patients. The pain levels at the start and end of the transfer were on average 4 out of 10. So our goal were to maintain patients' pain from the beginning of the transfer to the end of the transfer. So in order to do that, we had some information and teaching to the physicians to make sure that their patients were adequately pain controlled before transfer, because the PCA, the point of the PCA was to maintain their pain levels. And then, paramedics and patients were very satisfied with this, scoring close to perfect. So our interpretation of the study was, PCA for rural and remote transports are definitely feasible. That is our practice change for Golden. We rarely send anyone in acute pain without a PCA pump now. You'll note that most of our cases are orthopedic trauma and acute abdominal pain, and ortho trauma was 3/4 of the patients that we sent. And we see a lot of trauma in Golden. There's a lot of skiing, a lot of mountain biking. We're a recreational community, but there's a lot of these communities like Golden throughout BC. And Golden had the majority of transfers. That's probably because we were the site champions. We were the ones who, developed the idea. But also we're located, 3 hours away from our referral center, whereas Invermere is located, an hour and 15 minutes. So the need for communities that are closer to the referral center to have this PCA pump, it's, kind of unknown. This was a safe modality to provide pain control in the back of an ambulance. And like I said in my last slide, pain levels were maintained. So just concluding this, and then we can go to questions. Looking at our results and looking at the study just in general, the authors of the study felt like we could have vast potential for rural BC and in Canada. Like the majority of paramedics in Canada, over 90%, cannot provide IV analgesia in the back of the ambulance. So this is potentially a huge change. We feel, hospitals that are relatively close, within an hour to the referral center, may not get bang for your buck with the PCA, but those hospitals located like quite remote, like Golden, are probably the ones that are going to benefit with this. As Frank mentioned, this will be published in the CGEM. It just got accepted 3 weeks ago, and we're hoping to roll out this project in partnership with BC EHS and do some presentations with them. And as you heard from Megan a couple hours ago, we're hoping that we can roll this out, regionally in BC at certain sites that we've selected. Yeah, so I just wanted to thank RCCBC. They provided me a grant for working on this project, and as well, Jason's been really instrumental in helping me just think about research. I'm not a researcher. I never did research in residency, but I've been involved with 2 research projects just because I've seen problems that I wanted to fix, and I felt like data is the best way of doing that. So yeah, thanks, Jason, for doing that. Any questions? Thanks, Frank.
I'm not a researcher, but I see problems I want to fix. I collect data and I write it up. I mean, that's essentially what we do with research. So, by the way, I meant that your previous publication had been in CGEM as well. I didn't know this had been in CGEM, so I didn't mean to scoop you. Congratulations again. Obviously a flagship project for RCCBC. Question from Shiraz. Are the PCA pumps of proper the hospital or BCHS? How many pumps do you have available to use? Great study and program.
Yeah, that was a really good question. And sorry for those listening, I skimmed through like a lot of the details, but we only obviously have a certain amount of time. So each hospital provides their own pumps. Golden has 4 PCA pumps currently. I believe Invermere has 2 or 3. And what we do to make sure, because initially we lost a lot of pumps, we'll mark down which hospital the pump's from and a phone number, and even an address just to get it back.
You see what goes into research. You gotta even keep track of your pumps, right? I mean, this is stuff you never anticipate, but congratulations again.
Yeah, we lost 2 or 3 pumps in our first month.
Anyway, great work. Also great work lobbying BCHS. It's clear that your patients, your paramedics really are satisfied with this. Practice changing research, what more can you say? I mean, even some might be used in very urban areas, even though you said 90 minutes was a reasonable cutoff. I mean, just terrific work. And anyone wants to get in touch with Adam about how to do this, even though he's, not a researcher, even though he really kind of is, I would get in touch with him to see how to do this. Remarkably motivated, and congratulations. If there's any other questions or comments, we're going to move on to Hannah Young.
Hi, everyone. I'll just pull my slides up here. Okay, so my name is Hannah Young, and I'm a 4th-year medical student at the Southern Medical Program in Kelowna. So today I'm going to talk to you about a research project I've been involved with for the last 2.5 years in the traditional and unceded territory of the Syilx Nation. So the title of this presentation is Optimizing the Integration of Family Physicians into Post-Cancer Treatment Care in BC's Interior. So cancer diagnoses continue to rise worldwide with increasing survival rates within Canada. This is leading to a growing population of cancer survivors, leading to an increased strain on healthcare systems to provide something called survivorship care, which is the care of an individual who has completed active cancer treatment and who is now requiring cancer-specific follow-up care. So who is delivering this care? So traditionally, the role of the oncologist was to provide all aspects of the survivorship or the cancer care pathway. But due to the rising diagnoses, there's been increasing demand to provide active cancer treatment for oncologists. This has led to the proposition that family physician-led survivorship care may be a solution. And this model is already being utilized within the Interior Health region, but there's been no previous research conducted to see whether this data is being, or sorry, this model is being conducted effectively. So of note, other healthcare systems around the world have reported increased difficulty in providing this care in rural regions specifically. So this map represents the interior health region with the distribution of cancer care facilities and family physician locations and densities. So as you can appreciate, there's quite a variable density variable distribution of family physician densities across the region, and that the majority of the cancer care facilities, especially the larger ones, are more centrally located, leaving a large proportion of the region with possibly more difficulty in accessing cancer care. So this leads to my research team's objective, which is to look at the barriers and solutions to optimizing family physician-led survivorship care within the interior health region. So to start our project, we conducted a scoping review of existing literature across other healthcare systems, looking at the barriers and solutions, and then using this as a framework to guide our own research within the interior health region specifically. So our research project, looking at barriers and solutions to family physician-led survivorship care in the interior health region, we focused on the four most common cancers in BC, which are breast, colorectal, prostate, and lung cancers. We used a mixed method approach, mailing surveys to all family physicians and oncologists in the interior health region, and conducting semi-structured interviews with a subset of this population. We used descriptive statistics and COBIC thematic analysis to analyze our data. So moving on to results, over 25% of family physicians and 96% of oncologists responded to our surveys. And we interviewed 13 family physicians, 6 practicing in urban settings and 7 rurally. We interviewed 9 oncologists, 3 medical, 3 radiation, and 3 general practitioners in oncology. So surveying family physicians and oncologists on whether they believed geographical factors hindered confidence in providing in family physician-led survivorship care, you can see that over a third of both groups thought that this was a concern in the interior health region. Moving on to more results from our surveys for the breast, lung, prostate, and colorectal cancers, we asked both physician parties whether they believed that that family physician-led survivorship care was affected by several barriers. So looking at the figure here, the pentagon here represents the proportion of respondents that agreed with the survey question, with the center being 0, the outermost ring being 100, and the red line representing the 50th percentile. The barriers that we asked about were insufficient knowledge of family physicians to monitor cancer recurrence, insufficient knowledge to monitor treatment side effects, lacking communication networks between family physicians and oncologists, insufficient resources for family physicians, and whether the survivorship care of these cancers fell within the scope or outside of the scope of family physicians. So the light blue shading represents the view of the oncologists and dark blue of family physicians. So first I want to highlight that both physician groups agreed that survivorship care of all 4 of these cancers fell within the scope of family physicians. Next, that both groups again agreed that family physicians had insufficient knowledge to monitor treatment side effects of all 4 cancer types. Looking at knowledge for monitoring recurrence, so for breast cancer, both groups were in agreement that family physicians had sufficient knowledge to monitor breast cancer recurrence, and that for lung cancer, they had insufficient knowledge to monitor lung cancer recurrence. Looking at prostate and colorectal cancers, the physician groups differed in their responses, with oncologists believing that family physicians had insufficient knowledge to monitor for recurrence of these cancers, and family physicians reporting the opposite. And these differences were statistically significant. Lastly, for the final 2 barriers that we looked at, lacking communication networks and insufficient resources, there was mixed responses from family physicians and oncologists, and the responses were around the 50th percentile. Moving on to results from our qualitative interviews, we based our data into 3 main themes, with the first being the current state of family physician-led survivorship care in the interior health region. So family physicians and oncologists both reported that this model of care was generally well accepted, but highly dependent on information and discharge summaries from oncologists, And it was also highlighted that more common cancers fit the model of care better than less common cancers. Some participants did voice concern over the provision of survivorship care in rural settings. Next thing we looked at was barriers that impeded the effectiveness of this model of care. And several folks expressed concern over the variability of the length and content in discharge summaries provided by oncologists, as well as the burden or the lack of compensation to conduct, to create these summaries. Insufficient resources for family physicians when these transfer or discharge summaries were not available was also noted as a barrier. And this can be resources such as guidelines. Lack of solutions for patients with no family physician was also a significant barrier. So moving on to our last theme, solutions to optimize family physician-led survivorship care in the Interior Health Region. So accessible and promoted survivorship guidelines and standardized discharge summaries, in addition to clear point of contact at BC Cancer for communication, more educational opportunities, and compatible electronic medical record systems and tools for this survivorship care pathway. So how does this data apply to survivorship care in rural communities? So Interior Health is a largely rural region, and it's promising that both oncologists and family physician groups largely supported the model of family physician-led survivorship care here. It's important to note that over a third of both groups expressed concern over the impact of geographical factors on this model of care. And this is likely multifactorial and can be due possibly to the variable distance to cancer care centers and the variable family physician densities across the region. The role of general practitioners in oncology is very crucial in these regions and can really help to mitigate these barriers. So overall, optimizing supports for family physicians may allow for more comprehensive care for survivors or cancer survivors living in rural regions. So what have we done with the research so far, and what are the future steps? So the scoping review that we conducted to inform our project was recently published in the Journal of Cancer Survivorship. We're also working on preparing a manuscript for publication of this current research project. And in the future, we are going to conduct a study looking at patient perspectives within this care pathway, as well as connecting with organizations such as BC Cancer and the Family Practice Oncology Network to implement findings from our data and our research. I'd like to acknowledge members of our study teams and partners that have helped support our research. So thank you very much. Does anyone have any questions or comments?
Well, thank you very much. That was very well done. It's pretty comprehensive the way you've explained it, from the fact you've already published some of this and the fact you're planning to publish more, as well as the links you have to try and disseminate the research and improve care. How did this project come about? Was this something developed by primary care physicians, patient advocates, oncologists who noticed a care gap? How did this start?
So it actually started through the UBC Center of Chronic Disease Prevention and Management Incubator Initiative. I'm not sure if you're familiar with that, but it's essentially where practitioners in BC can propose a research question to be connected with an academic researcher within the program, and they can move forward with research. So it's really great that way. So it was the overall project was started because there was some variability in the provision of this model of care within the Interior Health Region, noted by some oncologists. And this led to the research question being sent to the incubator initiative and then connected everyone. And then I joined this project along with one of my other medical student colleagues as a flex project, which Megan explained earlier, which is through our medical program, and then just continued on from there.
It's actually really interesting because the last presenter also said, I have a question. I see a gap in care, and I'm going to try and find some data and see whether it's legitimate and do something about it. That's two straight projects we've had that have started off like this. But it's also interesting to know for the rest of the audience, what resources are there? Because a lot of research starts from, you know, somebody noticing a care gap somewhere, a difference in care, difference in outcomes, or difference in populations, and knowing what the resources are. A lot of people notice this, but saying, you know, I don't have the resources, I don't have the time, I don't have the funds, I don't have any collaborators, but it actually, there is some, there's definitely some options out there. I don't know if anybody wants to, you know, message Hannah privately about this, but it sounds like a really good care option. How long has this project been going on? Because it seems pretty well developed.
Yeah, it's been about 3 years now.
Yeah, that makes sense. You can also tell if you haven't done this before, the time frame here, it's not like it's 20 minutes. I mean, it takes a long time to get people together, develop consensus, to publish the data, and then to transmit as well. And you know, by the way, I'm also going to say your graphs with the little pentagrams are actually pretty terrific. Question from Danielle Whitall: with the family physician shortage and other mentioned barriers, do you feel support coming from specialized survivor programs with qualified professionals bridging the gap from the oncology setting to community would be beneficial? I would love to get your email to take this offline to discuss.
Yeah, I would love to give my email here. I can send it in the Q&A. Sorry, that was Danielle Whitall.
That was Danielle Whitall, W-I-T-T-A-L. And then from Diane Orabeek, hope I'm pronouncing that right, more information about the incubator program. Also from the BC Rural Health Exchange, more information about the incubator program. You've got some links there. So for motivated people in the audience, there you go. If you have a clever and burning question, there's some options there.
Yeah, and just a quick response to Danielle Whittall's comment. We actually did present our research at the BC Cancer Summit last week, and had a number of individuals reach out with different projects that they've been working on in the Interior Health region and across the province. So we are very open to connecting with other folks doing research in any aspect of cancer survivorship care, or any way that our data can be applied. But thank you all very much.
Any other questions or comments? Does not look like it. So we're a tiny bit early for Abby Hutchinson and Bruce Wallace.
Hi, I'm going to start our presentation for Abby and I. Our presentation this morning is on expanding drug checking services outside of urban centers. And Abby and I are based in the University of Victoria, Abby Hutchinson in public health, and myself in social work. And we're presenting also on behalf of the co-lead, Dennis Hoare, who's in chemistry and computer science, and our whole substance drug checking team. Next slide. I'd like to acknowledge the territories that we work in and live in. We live in Lekwungen territory on the southern island, but our services are extending now towards other territories such as Nachalnuf and the Kwakwaka'wakw and other territories, as we will be talking about how we try to scale and reach drug checking throughout Vancouver Island. Next. The goals of our project, so we're providing drug checking as an overdose response to the overdose crisis in BC. And so the goals are that we're being able to offer drug checking services to individuals, and then also reports from drug checking in those communities to the general public and to public health also. We're funded as a pilot project primarily through Health Canada. But we want to make sure that we're not having that traditional limitation of a pilot project. We really want to try to figure out how we can have scale and reach to have impact on the overdose crisis. And some of that also means taking a more systemic look at the issue. So not just addressing someone's individual sample and their individual drug use, but the overall context of stigma and criminalization of people who use drugs. And finally, we're doing this as implementation research. And so as we implement drug checking as an innovation in harm reduction, we're also doing research alongside of it. Next. So our main site is in Victoria, and this is a picture of our storefront site. And we're really excited about the storefront in that it really does have that goal of scale and reach. It's not located within one certain health center, but actually as a storefront so that general public can reach us as well as anybody else who could find the service useful. But the limitation is you have to walk through that door to be able to access drug checking. And this was going to be the only service on the island. And so we knew that we had to try to come up with alternative service delivery models to be able to reach people who would, geographically just can't be in that setting. Next. So that's where scale and reach come in. And our project is informed by principles of health equity. And so within health equity, scale and reach are two really important principles. And by reach, we mean being able to geographically reach other communities and other areas, but also reaches for underserved communities. So how to tailor services to best reach different communities that could use the services. And then scale, as I said, is to have meaningful scale. So we know that the overdose crisis is impacting all of British Columbia and every community. And so we need to be able to have not just small pilot projects, but actually have meaningful scale to the responses. Next. So this is the service model that we've been developing and researching, is that we tried to set up a distributed service model with sites up throughout the island. And so currently our current sites right now are in Victoria, but also Port Alberni, Campbell River, Duncan, Sooke, and Courtenay Comox Valley. So the central hub is that storefront that we showed, and that's where most of our spectrometers, including a mass spectrometer in collaboration with Vancouver Island University, is all located, and our main technicians. But that site then is linked through our secure database to these other rural areas so that people can send us samples from the overdose prevention sites in these smaller and rural serving communities. And we can provide all the interpretation and the results in real time back to these smaller communities. So it's a distributed model that combines some of these immediate test results in places where people have the personal connection with others. Plus, we also have an online and mail option. So people can actually access the results send us results from their home in the mail and get the results on their phone or back at home. And we think this is the best way to be able to provide some of that scale and reach that's going to go beyond an inner city or urban area. Next.
So I'll talk a little bit about some recent research that we've done about the scale and reach. One of the things we did to begin the scale up of services was hold pop-up drug checking in Duncan, Campbell River, Port Alberni, and Comox Valley. In total, we interviewed 27 service users and 12 service providers. Recognizing that many harm reduction interventions are developed for and implemented in urban environments, these interviews were meant to gain insight on the structural and social factors that should be considered when bringing drug checking into non-urban communities. 6 major themes emerged surrounding the structural and social environments of non-urban locations as it related to accessing and implementing drug checking. Based on previous experiences that participants had with harm reduction services within their communities, it was anticipated that the overall social and political climate would be a significant factor. People may be unwelcoming to drug checking and may not want to see it close to their homes, businesses, and schools. In many cases, participants also noted that their local town council may not support drug checking. Despite this, there was also expected to be support for drug checking within the community. Participants recognized the wide-reaching impacts of the unregulated supply. Many people within their towns have lost loved ones. As a result, they may see value in drug checking and welcome the service. Lack of anonymity within the community was a major theme discussed by service users. Everyone knows everyone was a common phrase used, and people may be afraid to be seen accessing the service by friends, coworkers, family members, or neighbors. For some people, this could have major implications for their job and housing security or risk involvement of child and family services. Some service implementers discussed existing strategies that they use to protect on anonymity of service users that could also extend to drug checking. Even though the lack of anonymity in a small town may be a barrier when accessing services, service users also commented that a smaller community was conducive to building a tight social network. Often, the harm reduction sites also function informally as a social gathering site. Because drug checking was planned to be implemented into existing harm reduction sites, participants thought that the tight social communities at the existing sites would help facilitate access to the new drug checking services. Resource scarcity was a common theme discussed by participants. Restricted hours of operation, lack of available staff to implement and run drug checking, and lack of available funds to support the project were all factors expected to cause barriers. When it comes to resource allocation, participants expressed feeling deprioritized and like an afterthought compared to urban centers. Most participants discussed the geographic profile of the region as being a significant factor for the accessibility of drug checking. The surveyed sites often acted as a service point for surrounding rural and remote areas, and people often described having to travel long distances to access services. People described their personal strategies to overcome this. Often lack of public transportation was a big barrier as well. So people hitchhiked, biked, caught rides with friends or family members, but these methods were also described as being inconsistent or unreliable. Finally, criminalization was cited as a significant barrier. While some participants did not have hesitation about entering a drug checking space with substances on them, others did have that hesitation for fear of police involvement and arrest, and the significant implications that would have for their life and overall well-being. These themes demonstrate that social and structural factors related to the implementation of drug checking in non-urban communities are complex and diverse, but people with experiences accessing services and implementing services within their communities provide valuable insight. We'd like to extend gratitude to our partners, to the Substance team, and to the BC Health Research Exchange for having us. We will now open for questions.
Thanks for doing this. Obviously a really important initiative. I don't see any questions or chats yet. First of all, I didn't see this, but maybe I just didn't notice it close enough. Who funded this?
I can go. It's our main funding is through Health Canada's SUAP, the Substance Use and Addictions Program, which has a 5-year project. And then we've been able to combine some of that service grant with research grants. And part of the multidisciplinary project is that we have some coming from the public health social work side that Abby and I are on, and then other ones from the computer science and instrumentation of the chemistry side. So part of the technologies to link the rural communities to the urban hub is to be able to have instruments that actually don't require high-level technicians in all the sites, and having the spectra be able to communicate through a secure database. And so all of that technology part's part of the UBIC part that Abby and I are able to put the public health opinions to.
Alrighty, so yeah, so it sounds like you almost had to, this wasn't exactly handed to you on a silver platter. You had to fight for it if you're going to get Health Canada funding. It sounds like it's competitive funding, right? Am I right about that?
Yeah, it's competitive, and it's also intended to be a pilot. So Health Canada's jurisdiction as a federal funder is to help support the innovations, but not to be able to sustain them. At that point, it's supposed to move over to more provincially and regionally. So that's what we're reaching in now in the next when March comes around.
Always a challenge between transitioning between a pilot and the real kind of project. How many, again, maybe you mentioned this, but how many people participated in your sort of feedback or your I guess, survey? How many people was that? And were they from geographically varied areas across the island or concentrated at one site?
Yeah,
how did you solicit feedback? Again, it's a group of people that may, be very reluctant to engage sometimes.
Yeah, so we interviewed 11 or 12 service implementers and 27 service users. And so those were from all the locations where we're scaling up services. So Campbell River, Courtney Comox, Port Alberni, and Duncan. So at the same time, we were also doing pop-up drug checking. And so the folks that we interviewed who were service users were already using the service because they were in sites such as like overdose prevention sites, shelters, things like they were already accessing. And so we were able to facilitate connection that way. Often the service implementers also help facilitate that connection.
Pretty impressive to be able to do that. Again, it's, you know, I'm in downtown Vancouver where, you know, we're at St. Paul's Hospital, which if you don't know St. Paul's, it's, you know, there's a lot, you know, the downtown east side has a lot of sad stories. But, you know, it also has a lot of resources, a lot of drug checking, a lot of overdose prevention sites, a lot of harm reduction sites. It's got insight and total lack of criminalization essentially lack of criminalization for simple possession by the police. I was interested to hear that in some areas, you know, I guess you still risk, you said criminalization probably just for a simple possession charge. I imagine that must make it a bit more difficult than in downtown Vancouver. It's all these social factors that I might not even consider. So is it different now? You're based out of Victoria, and Victoria doesn't exactly qualify as rural to me, but, you know, how did you establish connections across the island with very different areas? It'd be very difficult for me, for example, to establish connections with smaller centers across Vancouver Coastal or Fraser.
Yeah, I think part of it is doing community-based research, and Abby's, you know, doing patient-oriented research along with Island Health and other at the BC Support Unit. So as community-based research, I've been working in harm reduction for decades. And so it is that ongoing relationships with drug user organizations and harm reduction organizations that when we have an issue, we're able to already have some of those relationships in place and then be able to respond and also have that trust in place. But I think just to go back to Vancouver and the downtown east side overdose responses, I think what's really clear is that, you know, those models and methods that are responding to the overdose crisis there are likely not as transferable to the province, and the rates of overdose are often higher in non-urban settings when it's on rates, not numbers. And so I think, you know, why again our multidisciplinary project, I think one of the benefits is that we really see the need to figure out some of the technological innovations and the staffing innovations so that it's actually affordable and that it's realistic to be able to provide services in real time to these communities, but in ways that isn't going to require the same level of staffing that you might find in a downtown east side site. And so that's, I think, what we're really trying to explore and how that can go even beyond the island.
Great, thank you very much. Are there any other questions or comments from the audience? In that case, thank you very much. You know, obviously, you know, ongoing, we're now year, 6, 7 of a state of emergency. So please keep going with your hard work. Often, like I said, the downtown east side gets a ton of attention in the media, but it's really the smaller sites where people don't have the resources, where there's not enough Narcan getting handed out, where opioid agonists there can be tough to find. Those sites need a ton of support as well. So thank you very much. All right, I guess next is, I believe, Sage Thomas.
Okay, can everyone see the slides there? All right. Hello, everyone. My name is Sage Thomas. I'm a registered nurse, and I've lived and worked in rural communities throughout my life from Manitoba to Vancouver Island. I've primarily worked in community mental health and substance use settings, both in generalist and specialist roles. And I'm currently doing my Master of Science in Nursing at UBC Okanagan. I value equitable, community-oriented healthcare. And I'd like to acknowledge that I'm a settler speaking on the traditional, ancestral, and unceded territory of the Syilx peoples. I'm learning what this means beyond reading these words, recognizing that action and relationship are integral to decolonization. So to start, the Canadian Association for Rural and Remote Nursing estimated that in 2016, 10.8% of Canadian nurses worked in rural or remote locations. This amounts to 43,529 nurses across Canada. These nurses work in public and community health, inpatient units, emergency departments, long-term care, outreach, and outpatient settings. These settings are more isolated from services and specialists with fewer resources compared to urban settings. These services are also more impacted by environmental disasters and may have poor access to communication technology. Due to the diverse patients and wide-ranging healthcare concerns they are presented with, rural nurses often have a multi-layered generalist practice with mental health as one component. Within Canada, an estimated 20% of the population is experiencing a mental health or substance use disorder in any 1 year. Underserved communities like people living in rural and remote regions, people who are Indigenous, racialized, or part of sexuality and gender diverse populations tend to have disproportionately higher rates of mental illness and worse mental health outcomes. Compounding these inequities, mental health services may be absent, difficult to access, or sorely inadequate. People living within rural communities also face greater mental health stigma. In this context, rural nurses are often the first point of contact and the main professional support for those with mental health challenges across healthcare settings. So in light of this information, I conducted a rapid review. A rapid review is a brief systematic review of the literature on a specific topic completed in a relatively short amount of time. This rapid review was completed in the spring of this year, looking at international studies of what is known about rural mental health nursing. I included specialist and generalist practice, so any nursing practice that tends to someone's mental health. I located relevant literature by searching the databases CINAHL, Medline, and PsycInfo for articles about rural mental health nursing using the concepts of nursing, rural, and mental health. I included articles from 2012 to 2022 written in English that were peer-reviewed and had an available abstract. Overall, I located 122 articles and imported them into Covidence, a screening and data extraction tool. I screened the titles and abstracts of 105 articles, the full text of 41 articles, and finally, I included 10 studies related to rural mental health nursing in this rapid review. So what did I find out? There are 10 international studies conducted in that time frame from Australia, Canada, Indonesia, Sweden, and Vietnam. 6 were qualitative, 3 were quantitative, and 1 was a mixed methods study. Across these international studies, I identified 4 themes: nurse characteristics, the nursing role, the work environment, and the community context. Most nurses in these rural studies were women RNs with ages ranging from 25 to 70 years old. Many nurses endorsed a lack of mental health experience or training. Some nurses described low self-confidence in providing mental health care. Some nurses were coping with stress, burnout, and distressing emotions. Becks et al. Underscored how nurses were working hard to provide good mental health care despite the challenges they faced. The studies described a nursing role that is generalist, with mental health typically only one component of a wide scope of practice. The nature of the generalist role may make it hard to prioritize mental health care amidst the high workload, competing demands, and complex client care. Nurses also described ethical issues such as balancing client autonomy with client safety and being in a dual role where personal and professional lives collide. The nurses worked in a variety of environments: general hospitals, urgent care, mental health clinics, community centers, client homes, and remote areas, including Indigenous communities. Some nurses in the studies worked in multiple practice settings. Most studies reported that there were inadequate resources in the nursing practice environment where nurses were trying to meet the mental health needs of patients and clients. These resources spanned from a lack of workplace supports to supplies, relational, structural, financial, time, and safety resources. 2 out of the 10 studies reported that nurses felt well supported by leadership and coworkers. Studies reported on some of the challenges nurses face when navigating the mental health care system, such as transferring patients to a higher level of care, accessing mental health support via telephone, or accessing mental health assessments in person. Half of the studies found that rural nurses face a significant risk of violence. In one study, the workplace culture reportedly compounded and contributed to the risk of violence by being complacent about or normalizing violence. Half of the studies reported on the isolated environments rural nurses work in, both in the practice setting and within the community. Over half of the studies described the rural and remote locations that nurses worked in with access to few or no mental health resources. 2 studies reported on the relationship between the nurses and the community, noting the positive impact of having a connection with Indigenous workers and other community members in order to better understand the community's concerns related to mental health and be able to partner with the community to address these concerns. Stigma was woven throughout the data and fits under more than one theme. Stigma was described as being directed toward mental health patients from nurses, toward nurses from urban healthcare providers when training in cities, and from community members toward mental health nurses. The broader literature on rural nursing reflects the findings that rural mental health nurses work as multi-skilled generalists in dual roles in often resource and infrastructure limited environments. Perkins et al. Corroborate the findings that rural communities are typically poorly resourced with multi-layered challenges that are unique compared to urban communities. And in terms of addressing these challenges, Perkins et al. Advocate for applying a rural-centric view rather than replicating urban-centric approaches. Olkey and Lintz Martindale add that in the Canadian context, it is crucial to meaningfully involve Indigenous peoples and people with lived mental health experience when looking at and acting upon changes needed to improve rural mental health care. Future research is needed around mental health nursing in rural communities, looking at how to attract, retain, and train nurses in rural areas, appropriately support rural nurses with mental health in their practice and support their mental health, and support community collaboration. Future research is also needed to look at under-researched areas such as community and primary care settings and child and youth mental health. More Canadian and qualitative research is needed. And importantly, we need to meaningfully include people with lived experience and lived mental health and substance use experience and Indigenous, racialized, and gender diverse people in research, both care providers and patients or clients. So this rapid review did have a few limitations. It was limited in scope due to the short time frame, and the date limitations decreased the number of articles included. And there was only one reviewer, myself, for the rapid review. So I am in the process of removing the date limitations and collaboratively rerunning this rapid review with the goal of publishing, and will be addressing these limitations throughout this process. In conclusion, through this rapid review, I pulled the rural mental health nursing research internationally together from the past 10 years, which revealed a complex nursing practice reality that is both under-resourced and embedded in isolation in workplace settings and geographically. These nurses are typically generalists and may lack access to mental health training, support, or resources. But despite these challenges, rural nurses are working hard to support the mental health of the patients and clients they care for. So going forward in my thesis, I'll be partnering with the Canadian Association of Rural and Remote Nursing and the Community Health Nurses of Canada to explore the experience of rural nurses providing mental health and substance use care to children and youth in community-based settings. I want to understand what can be learned from these nurses and how we can best support them. Thank you.
Thank you, Sage. That's really well done. It's certainly, you know, the second talker we've heard the difficulties of, you know, applying lessons learned in urban areas to rural and remote areas. I trained in Alberta, where the model is maybe a tiny bit different. Whatever it is, they have a very large mental health facility in Ponoka, which is just a little bit north of Red Deer in the center of the province, if you're not familiar. And I worked for a long time in Hinton, Alberta, which is near Jasper. And what you would do with a you know, again, mental health, to me, the big divide is, you know, thought disorder versus mood disorder. You know, and obviously there's some overlap there, but I mean, that's kind of, you know, one way to kind of structure it. But patients with a mental health, this young patients, obviously with a mental health disorder and not too many other underlying causes, had to be ambulanced from Hinton, which is about a 5-hour trip one way to Ponoka. And then 3 days later, they'd come back, which I don't think we have that kind of model in British Columbia. I mean, I think you might be sent from, you know, if you're in, you know, Chase or, you know, or Coldwater, you might get sent to Kamloops, but we have a sort of a model where people get transferred 6 and 7 hours routinely from all across the province to a central intake site. And I'm wondering, you know, what kind of how these models developed. Is your, you know, when you did your research, did you find, you know, different models where there was sort of a, you know, a centralized, you know, facility or two in a state or a province, or is it more scattered like in British Columbia?
So in the research, because there were only 2 studies from Canada, most of the studies kind of focused on the actual nursing practice realities, which were mostly generalists. So they did speak about transportation to other facilities, but that wasn't much of the focus. That, like, they briefly talked about that being barriers, but it was mostly, you know, small hospitals responding in the moment. I can speak from experience though, working on Salt Spring Island, where we had, it was a very small hospital, and any significantly acute presentations, people would have to be sent off island. And that would be by either plane or by boat. And so that presented huge challenges. I think it's quite diverse across BC in terms of models. I know there are like one of the studies in Sweden, that was a specialized mental health clinic where it was actually a rural clinic, and they had other rural areas that would transport people to that clinic. Yeah, so I hope that addresses your question there.
Yeah, no, just so here's a question from Barbara Oki. Hope I'm pronouncing that right. In your rapid review, did you come across any literature which identified overlaps between some of the mental health nursing challenges in rural regions and the prevalence of resource industries in these areas?
I did not come across anything that discussed that, but I would be really interested to look at any research that might. And because the date limiters as well, I'm wondering if, you know, maybe there's articles that I missed that were older that would discuss that, but I'd be curious to learn of any overlap for sure.
Do you mean extractive resources, you know, mining, you know, forestry, fisheries? I mean, is that kind of what's meant by the question? You know, or, you know, because this people could develop chronic pain from lots of, you know, physical labor, or is it areas where there was a resource industry 50 years ago and the coal mine closed, now there's nothing except, you know, kind of despair, which we see and certainly see as well. So, you know, I just wonder if that question can be coned down a little bit. Feel free to speak, by the way. You're not muted.
Yeah, sorry, it's Barb Oak here. I work for Northern Health, and yeah, I was really just curious, just because with these, it's an area I work in, but a lot of these rural areas have a large temporary workforces, and they have their own unique kind of mental health challenges sometimes, and just kind of wanted. I was just curious if you came across any kind of overlaps, or if that came up in the literature at all, really.
Not that I came across, but I'd be curious to see if they're, like, with a broader review of the literature, if I do come across anything, because I think just from an environmental perspective, as I know Dr. Oki's, you know, there's research about the impact of the environment, but in terms of more industry-based, I haven't reviewed that at this point.
Hey, thank you. Yeah, I was just curious. Thanks.
Just to put things into context, I wonder if the challenges in, say, you know, Fort McMurray, which is like your prototypical boomer bust, you know, extractive resource town, would be different than, say, in Crowsnest Pass, which used to have a big coal mining industry, but now doesn't. It still has some mining and forestry around it, but certainly not as much as it did 50 years ago. So I'm wondering what the challenges would be different in those sites. And I know one of my friends used to be the medical officer of health for Fort McMurray, and the challenges are pretty severe up there. So
significant, yeah.
Transient population as well, as opposed to Crowsnest Pass, where it's largely a non-transient population, for example. So fascinating stuff. All righty, any more questions or comments? In that case, Allison Ritchie, please.
Can you hear us?
Hello, do we have audio?
You do, we can hear you.
Oh, okay, all right. So our project is called The Effectiveness of Cognitive Stimulation Therapy in the Comox Valley. We're 3 occupational therapists that work with the Geriatric Specialty Services team, Allison Ritchie, who is the lead on this project, Kyle Hellman, and myself, Laurel Steed. We're frontline clinical staff. We're not actually researchers, but but we sort of went on this project, and it's sort of a quality improvement project of putting evidence into practice. So this slide shows a picture of our beautiful Comox Valley, where we live and work and play on the traditional and unceded territory of the Comox First Nations people. The slide beside it is a graph of the projected rate of growth of our population here in the Comox Valley, with the top line, the blue line, projecting the growth of those over age 75. And in the 20-year span between 2019 and 2039, that projected growth is 100%. Our current Canadian statistics show that those over age 85, 34.5% of them meet the criteria of dementia. Dementia is a disease of the brain. And simplistically, if we think of our brain as an onion, it is the peeling away of the layers of the onion, which for people living with dementia yields losses of memory, cognition, function, and secondary losses of social isolation, mood changes, overall quality of life for both the person living with dementia, their loved ones, and caregivers. Our team, the Geriatric Specialty Services team, provides traditionally comprehensive assessment with the provision of diagnoses, care planning, in-home strategies, and safety suggestions, education, and resources. But there is a gap being that of therapeutic intervention for people with dementia. And the knowledge that there was this program called Cognitive Stimulation Therapy, and it is the only recognized and non-pharmaceutical therapy available with research behind it. So we saw this as an opportunity to provide this addition to people that we service through our program, and perhaps to help slow the peeling of the onion and improve people's quality of life. So ultimately, this project was the delivery of a person-centered evidence-based group called Cognitive Stimulation Therapy to residents of the Comox Valley, and to evaluate the effectiveness of this with ultimately the goal of long-term sustainability and growth of the program.
So what is cognitive stimulation therapy? It's a psychosocial group therapy program run by 2 trained facilitators with 5 participants previously diagnosed with mild to moderate dementia. This program runs twice a week for 7 weeks, and each session is 1 hour long. So the emphasis here is really on learning to improve focus, language, communication skills, and delay cognitive decline. And how do we do this? Well, we aim to create an optimal learning environment, as we know that persons living with dementia greatly benefit from structure, routine, familiarity, and predictability. Each session is structured the same way at the same time and place. Each person has their spot at the table. We open and close the group with a chosen group song. We do a physical game to get the blood flowing. We read and discuss a current news article. Then we introduce a differently themed activity each week designed to stimulate different areas of the brain at the just right challenge. We use positive reinforcement, a focus on opinions and feelings versus facts. We guide participants to use their stronger long-term memories into current times to encourage new ideas, thoughts, and associations. It's really important that the people feel included, and it has been so wonderful to watch our participants come out of their shells, connect, and support each other. There's a lot of laughter and implicit learning. The emphasis on having fun, we believe, is the reason for our very high rate of attendance. So why is this important? Improvements, the research tells us that improvements in thinking skills and reduced social isolation provide improved quality of life for people living with dementia and their caregivers. We heard from our participants and their loved ones that participating in the group made them feel less alone and more hopeful in their dementia journey. The caregivers also noted it made it easier for them to cope at home. This person-centered care is investing in people and their quality of life. So where's the evidence? We first heard of cognitive stimulation therapy when we participated in a facilitators workshop hosted by the Canadian Association of Occupational Therapists. We learned that CST was designed and evaluated by Dr. Spector in the UK. CST continues to be well researched and is expanding into 34 countries internationally. It is the only non-drug intervention for mild to moderate dementia with sufficient evidence to warrant recommendation by the UK's National Institute for Health and Care Excellence. That's NICE 2018. Also, a randomized controls trial in 2003 demonstrated that CST has comparable outcomes to cholinesterase inhibitors and is the standard of care in the UK. Our research team at Island Health assisted us with a systematic review and meta-analysis of the evidence, and the robustness spurred us to find out what the effectiveness would be in our community. We started our first group in the spring of 2022 and are in the midst of our second group. And Kyle will now discuss our preliminary results.
So how were our impacts measured? Well, we recruited our participants, as Allison mentioned, from clients who were already involved with our team. The inclusion criteria included having a diagnosis of mild to moderate dementia. We completed individual interviews with participants before the program began and administered two standardized measures. The first was a quality of life measure that was designed for people living with Alzheimer's disease. And the second was a common cognitive screening tool, the 3MS, which we had an extracted Folstein or the MMSE out of that. So we repeated these tests after the program was completed. We also ran a focus group on the last day, which was audio recorded for later analysis. And we asked caregivers to complete a separate paper survey. And finally, with the tremendous support of the Island Health Research and Capacity Building team, the data were analyzed using a mixed method pre-test, post-test design. So what did we find? So in terms of the qualitative outcomes, we can say that our data is in line with the international evidence on the benefits of cognitive stimulation therapy. So after 2 months of participating in the program, we saw a 2 to 4% improvement in cognitive scores on the Folstein. We saw an 8.5% improvement in reported quality of life measures. 100% of the participants recommended the program. And really, we heard from the participants and their care partners that this was really a unique program that wasn't available to them in any other way in the community, and no other programs of its like. So as part of the mixed method study, we completed a qualitative analysis of the voices of participants, and a number of themes were identified. These include social wellness and connection, enjoying engagement with new ideas and challenges, feeling an energized focus or being in the zone, experiencing the program as a stigma-free safe space. Additionally, caregivers told us that the support and relief from caregiving was extremely valuable to them, and also that their loved ones appeared less socially isolated and cognitively quicker after participating.
And our obstacles are that although we long recognized a gap in care, high caseloads on our team have made it difficult to action change. And also in these times of tight budgets, we needed to ensure cost effectiveness of anything that we started. Our team here hadn't done any research in a while, and we lacked a bit of confidence in getting started. We also didn't have the physical space to run the groups. So how did we overcome these obstacles? By collaborating. We collaborated with our team and managers who supported our vision and provided referrals and extra workload to focus on getting the program started. Amanda Letty at Island Health Research and Capacity Building was instrumental in encouraging us, providing a roadmap, assistance with evaluation and data analysis. Providence Living in Comox generously provided space to run our groups. Conclusion. For this quality improvement project, our first sample so far confirms that CST is working as intended, and we are excited to continue with our second sample. Our goal is to sustain this program in our community and assist in spreading it within Island Health. We learned that with teamwork and collaboration, we can make a difference in the lives of people living with dementia. And we have some quotes from our participants to testify to this.
One participant told us, "This group was so worthwhile. No one is uncomfortable. We learned a lot while laughing and having fun. The negative thoughts I had about myself went away with being with others experiencing similar difficulties."
Another participant said, "I have not made any new friends in 4 to 5 years, and I didn't expect for it to happen for me again. I am so grateful for the new friends I've made in this group."
And a further participant said, "Initially, I did not want to do this group due to my background in healthcare, but I quickly realized that I needed this group. I've talked more than I have in a long, long time." As we close, this last slide is just on the left. Frankie McCaffrey was a client of our program who passed away, and her husband left a generous donation, which really was instrumental in us having some funds to start the program and get the supplies needed.
Thank you. We also wanted to acknowledge all the people that helped us with this, particularly the research participants and their caregivers, and our team and management, and Amanda at Research and Capacity Building, Jasmine Erdahl, our research volunteer, Providence Living for the space, and of course, Frankie and Jim McCaffrey for their philanthropic donation for the equipment via the Comox Valley Healthcare Foundation. Any questions?
Thanks for that. I'll ask a question. I'm here in the background. It's Jason Curran. Fascinating work. I'm curious about the conditions, optimal conditions for applying or implementing cognitive stimulation therapy. I'm wondering if you can kind of share some of the best, well, as I say, conditions for maximizing the success of that approach.
Okay. Yeah, sure. It's a great question. I think that for us, we know that people with dementia really do well with structure and routine and familiarity. So we meet at the same place at the same time. We're really careful that we're the same facilitators for every group. Everybody has their spot at the table. And then every group runs the same way so people know what to expect over time. But also, I think it's really important that we go and meet people before we start the group. So we have the great privilege that we see people in their homes with the geriatrics team. So we spend time doing, when we do their assessments, that we get to know people. And then over that hour and a half that we get to see them, they learn to trust us. And then when we make these recommendations to come into the program, they feel a bit safer about it. And then once they're in the program, we really focus not on facts, but on opinions that can never be wrong. So we don't ask people directly for information. Like, for example, if we're doing orientation, we wouldn't say to somebody, tell me the date today. Instead, we have it up on the board all the time. And we might say something like, oh, today's November 29th. Can you believe it's almost December? We just make it a kinder, gentler way, but people are still seeing the information and hearing the information. So we just really want to make people feel safe and comfortable. And I think having the peer support also makes people really feel like they can talk, because other people are making mistakes and we're not pointing them out or making them feel awkward. It's just a safe place for them.
And I guess I would add too, instead of it being like a wait list where your name has come to the top and you're entered into this group, I mean, we've only had one. It's about selecting a group that is people of the similar stage of dementia. So where you don't have people with early and then more moderate. So the group is a group of similar staged and able participants so that they can get the maximum benefit of the group, and that the group runs smoothly. And yeah, does that answer your question?
It does. Thank you.
Yeah, I think that was very well done. So, and we're going to thank you very much for that. Obviously, you know, very, very challenging to implement this, to convince people this is worthwhile going, but obviously had some very gratifying results, and really nice to include some of the testaments there. I'm sure that your participants, it really meant a great deal to them and their families. Dr. Brent Ohata, I believe is next.
Great. Thank you, everybody. And thank you to RCCBC for inviting me to talk. Great. Can everybody see the slides? Are we good? Thumbs up. Okay. So welcome to my section of the talk. This is improving delivery of virtual specialty and subspecialty healthcare for rural communities in British Columbia, an evaluation of a real-time virtual support pathway. So I'm Brent Ohata. I'm a rheumatologist based at UBC, and I work down here in the Lower Mainland, but I do a lot of outreach to rural communities in BC. And I think a universal theme amongst these are my disclosures, by the way. We're not talking about medication, so it's not particularly relevant. So, you know, a universal theme, you know, for practitioners in rural BC is that there's, you know, quite a lot of challenges accessing specialists and subspecialists. For example, within rheumatology, pretty much all of the rheumatologists, I think 75% of us or so, work in the Lower Mainland. There's a smattering in Victoria and in the Okanagan and in Nanaimo, and that's basically it. There's one guy in Prince George who's got, you know, a wait list of years plus. So one thing that we've been working on through RCCBC and RTVS have been these quick reply pathways. So the whole idea is anybody, you know, any nurse practitioner or family physician has, you know, a universal sort of Zoom account and has access to dermatology, hematology, rheumatology, neurology, et cetera, sort of at the click of a button through these pathways. They just click on the Zoom link. They'll you're almost instantaneously get linked up either to one of us or our MOAs who try to give like a relatively fast turnaround. The problem with this, though, is that the service has been around for maybe about 2 or 3 years and is being underutilized. So, you know, I launched this survey, which is still going on, to try to understand a little bit more why people aren't using this service more. And I thought since this is something that we want to expand, that we could ask a little bit more broad questions. We can try to figure out which communities are most in need of which specialists so that we can offer targeted like sessions with these individual communities to try to onboard them. We can see which specialists are needed the most, and therefore, you know, knock on the doors of our colleagues in other specialties to see if they're willing to join onto the program. And we want to see, you know, what do we need to improve our service so that this is utilized more. This is the survey. So, you know, really it's sort of like a 3-page survey that can be done online. Whoops. The first page is basically like a who are you, you know, set of questions like where are you working, how many physicians and nurse practitioners work in this community, and like what are the general sort of capabilities of the community, like are you able to access like virtual care and have high-speed internet and the computers to sort of reach out to us. The second page is just, you know, basically like a Likert scale of, you know, how much do you need the following specialties? And you just go through and click down. And then the third one is, you know, what are we doing wrong? You know, like, why aren't you using this service? How can we change this, et cetera? So this is actually a study that is not complete, but is in process right now. We launched the survey in September, and, you know, I was hoping for a lot greater response than what we've had. You know, we anticipate that, you know, the benefits of of completing this survey will advantage, pretty much all of the communities that we reached out to. We'll be able to figure out who we want to do outreach to. We'll be able to make these pathways more user-friendly, and identify characteristics of communities with higher needs. I mean, there's a fair amount of power that we have to offer, great analysis. If we have a large response rate to the survey, unfortunately, at this point, we only have about 20 responses or something, and I've been sort of knocking on the doors of everybody that I can to try to get people to respond. So that is the challenge. I don't have any findings to share because we're not yet done, but really the reason I'm presenting here is to get your feedback of, how do I get a better response rate? If anybody has any thoughts, and if you are a nurse practitioner or family doctor, then by all means do complete the survey. The link and whatnot, QR code are over here. But typically when I do surveys and stuff like that with the rheumatology community, we get pretty good responses nationally, like 40% or whatnot. So this was unexpected, and I'm wondering if anybody has any feedback, any tips for what I could be doing.
So it's Frank Schermeyer. I'm going to jump in here, and
sure.
How have you been disseminating these? Like, how are people supposed to know about this?
So the things that we've done, you know what? I could probably stop sharing. There's an email list of a lot of rural family docs that we've sent this out to, like as a blast email to a bunch of through RCCBC of all the rural healthcare practitioners. So that's one thing that we've done. There have been a number of different events that we've spoken at, like there was Northern Health Day where a bunch of rural family physicians all gather. That happened last Friday, that we tried to advertise at and tried to go around and talk to people about. There is a sort of like a CME event for the Northern Interior Rural Division of Family Physicians that I discussed this at. And there are, what do you call them? There are these like, basically like community, like virtual health liaisons or something like that. Basically people that work for, I think it's for RCCBC, and help them sort of onboard with a lot of virtual things. And they've been reaching out to their specific divisions of family practice, and it hasn't gone that well. So yeah, if anybody else has any other thoughts, any other avenues I can pursue, I think that would be amazing.
That's actually a bit discouraging. It sounds like you've done a lot of work, and when you see John Polowich, his name attached to it, I mean, he's a pretty influential guy, right? So, I'm kind of wondering exactly what's gone wrong here. I mean, only getting 20 surveys from across BC, especially for an issue that really impacts every patient, almost every primary care provider and nurse practitioner. It's a little bit baffling. Let's have a look at the chat here and see if there's anything there.
What about
through official physician health authority communication, such as physician newsletters, etc.?
Yeah, I think I can try that again. Like the one issue, like there are like a handful of divisions of family practice where they don't like. I think they're trying to prevent a lot of over surveying and over sort of bombarding of family physicians. So I mean, maybe that's the issue, but yeah, like any other ideas that anybody else has would be great. So
I'm a member of the section of emergency medicine, and once in a while that's with the doctors at BC. I assume you've already gone that avenue, right? That you've gone through family practice, the various health authorities, rural family physicians. I'm sure you've gone through all their mailing lists and their influence and their influential physicians, correct?
Some of these I haven't done. So, I mean, I think specifically reaching out to doctors at BC and seeing if that's a possibility is probably a good idea. Yeah.
Yeah, it's frustrating because this is a really good idea and it's requiring much more legwork than you anticipated on your part, especially with the methods that have worked for you pretty well. I don't have a ton of other answers. I mean, like I said, I'm an emergency physician. I'm just trying to come up with some stuff related. If there's anybody else, is there anything new here on the Q&A? Here we go. Brent from Barbara Buckley. I have the best results by using social media to get survey engagement. Is there
we've had people I am a technological Luddite for a guy who does a lot of telehealth, and but we have people on Twitter that work for our CCBC and have been sending out blasts and stuff like that on social media as well.
I guess the only other thing to think of is and it's going to require a bit of legwork here, would be maybe to reach out to the, you got to figure at every rural hospital, the vast majority of chiefs of staff are going to be family physicians or internists at the smaller sites, and they probably know their communities fairly well. Like I said, it's a lot of legwork, but I'm kind of wondering if reaching out to a single central influential physician would be, better than a random just email blast. Again, it's really labor intensive work, but you'd at least target it to your community. The thing is, if you have 20 physicians and they're all from, one or two communities, that's a pretty distorted view. And somebody, and they may even know, especially if they're say new around, they may even know that they need a rheumatologist very badly, or maybe they need everybody very badly. But say, just use a hospital that was earlier on, Mills Memorial Hospital in Terrace, if you were to reach out, again, there's 100 hospitals in BC and most of them are smaller rural hospitals. If you were to reach out to the chief of staff of the hospital, which can't be, I mean, it's going to be a couple of emails, a couple of phone calls to do for each one, but they would know, and they could probably comment a little bit better than just having slider scales as to what it needed. So again, it'd be more laborious, but I really don't have a ton of other suggestions because it sounds like you've already done most of the obvious steps.
No, I think that sounds great, and I think those are great suggestions. So
I'm gonna reach out to the audience here and see if they have anything else to add here. No, there's no place anything else new here. So feel free to reach out to Dr. Ojeda privately, I think. So
yeah, perfect. Well, thank you guys. I really appreciate the opportunity to talk.
You're very welcome. And Barbara Oak, I hope I'm pronouncing that correctly, is next to talk about resource extraction and development, the health services impact. Alrighty, which ties in beautifully to the question asked a few minutes ago. Ooh, and a nice picture of a tail. Is that a tailings pond up top?
Yes. Yeah, can you guys hear me?
Yes, very well.
Okay, perfect. Yeah, so thanks for having me here today, and especially for participants for sticking around for the last presentation of the day. So today I want to share with you some of the work I've been doing in my master's research related to the health service impacts from resource extraction and development, with specific focus from experiences from Northern British Columbia. And so before I begin, I want to recognize the traditional territories of Lheidli T'enneh and thank the nation for hosting me here today. So my name is Barb Oak. I'm currently a master's student at UNBC in the political science program, focusing on resource policies related to social and health impacts from resource extraction and development. And I also work at Northern Health as a technical advisor in the Office of Health and Resource Development. So for those that don't know, the Office of Health and Resource Development at Northern Health was developed in 2014. It was developed to intentionally improve our coordination, our understanding, our management of the interactions between Northern Health, the healthcare system, and the various resource development projects in the region. And so my research, you'll see, very much overlaps with the work that I do at Northern Health. And so today I want to share with you an overview of my research and then some preliminary findings with you. So my research questions is really twofold. It's what are the health service impacts of resource extraction and development? And then what lessons and promising practices exist to improve how these are managed and mitigated? Before I go into the specific research question, I just wanted to give everybody a bit of a lay of the land of just that interaction between resource extraction, development, and health. This is a figure that colleagues of mine and myself made a couple of years ago. And I know it's very busy, but what it's trying to show is that health is impacted by resource and extraction industry through somewhat complex and different impact pathways. So industry can impact the different social, economic, cultural, and environmental determinants of health. and different aspects of those, and these then interact with each other to then result in various health outcomes, sometimes positive and negative. And so my research question is actually just focused on a very small sliver of this much bigger body of work that's happening. I'm just really focusing on the infrastructure and services piece, which is the top right-hand corner, and focusing specifically on health services and infrastructure. And the reason why I'm focusing in this area is I've been working on impact assessment on behalf of Northern Health for quite a long time. And the impacts to health services when major projects come into town is a reoccurring theme that comes up in media, comes up at the community level, brought up by health agencies. It's found in gray literature. And so when as a political science student, what I wanted to initially do is actually look at policy related to these health service impacts and how do we improve policy. But when I went into the literature, the academic literature, not very much, it's very sparse on health service impacts. Generally, there's articles on like broader health impacts of social impacts, and they kind of gloss over that health service piece. And then the few that do exist look at just very narrow aspects, so like things like STI testing in one community, or more from a community development perspective, or resource communities transitioning away from the resource industry. So the question around like, what can you expect for health services when industry comes to town really isn't answered very well in the literature. There's a couple of articles that I came across, which I've listed here. But they're now quite dated. The one actually from 2021 is actually an account from 1918. And so my goal is really to build on the existing literature that does exist, and especially some of the gray literature and experiences in community. And so I thought Northern Health would be a great case study to look at this. I mean, I'm biased because I am familiar with this context and I work in this area, but also, as we know, Northern Health is a regional health authority that covers a huge landmass and is fairly sparsely populated. And that landmass is very rich in natural resources, and the communities in the region are very dependent on resource industries. So we've had some of the biggest capital expenditure projects in the last few years in all of Canada, and some immense workforces that have doubled and tripled the size of communities seemingly overnight in the region. And so a lot of these peak construction workforces occurred at the same time as COVID-19, which of course highlighted a lot of our vulnerabilities in our system as well. And so the fact that Northern Health has this office that's specifically looking to better understand and manage these impacts, I thought would offer some really great opportunities to capture Northern Health's experiences, their observations, and their lessons learned to hopefully help other rural health authorities related to these issues like this. So what I did, and my study is fairly small, but what I did is I recruited a handful of Northern Health leaders at Northern Health that I knew had worked over since 2014 with industry to try to improve how the health service impacts would be managed. And so I'm trying to capture really their observations and their experiences. And so I did this through either semi-structured interviews or surveys. It was up to the participants to decide, and recruited a total of 9 participants who were able to then share their stories and their experiences with me. And I then summarized the key themes and kind of the main things that came out of that. And I'm still in the process of now reporting on the findings with the hope of being able to publish those into a peer-reviewed academic journal. But also my main goal is to be able to use that information to help improve policy and decision-making around these major projects. So some of my preliminary findings, I have to say these are very high level because of the time limitations. There was some really, really awesome information that came out that was quite nuanced, but these are some of the kind of higher level findings. So the findings really confirm that resource extraction and development projects, they do impact health services. And these pressures are felt first and foremost on emergency rooms. There's pressures and impacts that are felt throughout the system, including things like primary care, maternity services, mental health services. So across the system, sometimes to critical levels, but first and foremost, it is the emergency rooms who are feeling these pressures, and we're recognized as somewhat like canary in the coal mines. And a lot of the pressures at the emergency rooms, definitely some of them are like high acuity kind of traumas that would present to emergency rooms from industry, and they can be quite challenging for small emergency rooms to deal with. But by and large, the pressures that we're seen as kind of more challenging are kind of ones that should be managed elsewhere or better, were the CTAS 4 and 5, so the lower acuity presentations from industry that were coming to the emergency room. And I think one thing that was highlighted, which I think is very important in BC's current context related to the human resource challenges that we're under, is that these pressures really do affect staff morale, or can affect staff morale and staffing levels. And the other interesting piece was that, you know, yes, industry does have, the industry setting does have some unique hazards and risk factors that can contribute to some unique presentations and healthcare needs, but by and large, the majority of the healthcare pressures really are just based on the temporary population, the size of the temporary population that's in the community to help support that project. So it's really population based. And then it follows that the relative size of the worker population, the temporary workforce, compared to the size of the community and the healthcare services is really the biggest indicator of the level of impacts that we will see. But also project type and how well things are managed can really impact how, you know, how impactful it is at the local emergency rooms. Overall, despite some of the variability depending on management and projects and things like that, there was kind of this consensus that this is not, when industry comes to town, that there will be pressure on the emergency rooms is not, shouldn't be a surprise. These pressures are predictable and are something to for. So when I asked
Nothing more, no questions. Right, I know you're going to sign off. Thank you.